Call the meeting to order. It's Oregon Health Policy Board, October 3rd, 2017, 8:30. Welcome, everybody. So today on our agenda, we have the director's report. I think we have just brief committee reports, and then we'll hear from the Health Plan Quality Metrics Committee, from the Behavioral Health Collaborative status and update, and then talk a bit about moving forward with CCOs. So a good agenda with some meaty items. Let's see, I think we have I think we have a quorum. I'm sure we have a quorum with 6 of us, and I want to check to see if there's anybody on the phone who's here as a board member. I didn't think so. So both Carla and Oscar won't be with us today. Otherwise, we're at full complement. Couple of things before we'll review the minutes in a second. I wanted to one comment on the legislative days that happened last month. The House Health Committee Chair Greenlick had asked me to come and present on behalf of the policy board and our work, both in terms of what we had been doing and what we see as our priorities as we move into the future. Some definite and specific interest in the future of CCOs. So it was a good conversation with the Health Committee as they're getting their legs under themselves again. And gearing up for the next session. I would anticipate that that they'll continue to be interested in a direct relationship with the policy board. And then I also wanted to just remind everybody that next month we'll be meeting in Astoria. We had talked about a couple of other communities in Columbia, Clatsop, Tillamook counties, and landed on Astoria because they've got good venues. And we were there a couple of years ago, but it felt like being out on the coast was important again. And you might remember that every 2 years we have a responsibility to meet at least once in each congressional district. We meet in the 1st district easily in Portland, but felt like it was important to try to get out to other communities as well. So we'll be in Astoria, and then we also had visited Tillamook last year with our CCO listening session. So trying to figure out how to engage those different communities. And then I think we should be able to come back, if not at the next meeting, pretty soon and talk about other plans for other places we want to go. Eager to both figure it out and to make sure that we are out in the rest of the state, possibly more than we have been in the past. So with that, I'll turn your attention to the minutes.
Ask a question?
Yeah.
My sense is that there's going to be some folks who are going to go down the night before. I mean, it's feasible to drive from here, but if there's folks the night before and there's anything, a dinner or anything, I'd love to go down the night before just to, get a chance to interact with folks and all.
Yeah, we talked about potentially trying to do a tour or something, meet with some folks in the community the night before. We haven't really gotten too far into the agenda. We've reached out to the CCO and would plan to reach out to some of their stakeholders and think about, what the right, types of visit potentially could look like. But if folks are interested in that, that's was our current thinking, was to do something the day before.
Yeah. I think I mentioned I read Astoria. If you haven't read the book Astoria, it is incredible.
It's on the plate.
I need to send my regrets in advance. It's the same time as the American Public Health Association meeting, which is a must-attend meeting for me, but I might be able to listen in by the phone.
Thank you for that. Yeah, no, I think the visits to other parts of the state often work best when there's an opportunity to do a visit with what's happening on the ground there. So hopefully we'll get a chance to do that. I definitely plan on going out the night before as well. If nothing else, John, you and I can have dinner.
Yeah, I got the dog room already.
I'll be
I
out
think.
there the night before.
There we go. Okay, so I'll turn your attention to our minutes from the September 12th meeting. Is there a motion to accept the minutes?
So moved.
Great.
Second.
It's been moved and seconded that we accept the minutes from the September meeting. Is there any discussion?
I appreciate the changes, thank you.
Yeah, more detail, and to that end, the staff is definitely interested in making sure that we're codifying our discussions effectively. So if people have other thoughts about what to make sure we're tracking in those minutes, don't hesitate to let staff know. Okay, all those in favor of accepting the minutes from the September meeting, say aye.
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 Any opposed?
Zeke, I'll recuse since I wasn't present.
Okay, thanks, Karen. Great, motion passes with one recusal. Minutes are accepted. And with that, I think I'll turn it over to Director Allen. Oh, actually, I should just acknowledge, I'm going to acknowledge. Since we last met, as people probably know, the governor announced that she is putting forward Director Allen to be in the role permanently. So I think we can almost officially move away from the interim term. There's still the Senate affirmation, but it sounds like we're going to be with you for a while, Pat, and that's a good thing.
I appreciate that. Well, thanks. I've just got actually very brief comments. Last Friday was the end of the first full month for me and for most of our team. And on the one hand, a month seems like a while, and on the other hand, it seems like so much longer than a month. With the just the sheer amount of stuff we've been doing and trying to get our arms around and understand and those kinds of things. But I think it's generally been a good month. I think we've had really encouraging response from staff and stakeholders, and we've been working especially hard on relationships and transparency and those kinds of things. And I think we're making some good progress. We also had several command performances for Ledge Days at both the House and Senate Healthcare Committees, and then the Government Oversight Committee to talk about past events. And those generally went, I would say, kind of uneventfully. We got a fair amount of questioning at House Health on the action plan to deal with the redetermination backlog. And some questions we're trying to run down now about how to phrase it, the amount of health care spent on people who were not timely redetermined, which is maybe a little bit different phrasing than the people who weren't qualified, because of course you're qualified for benefits until you're determined not to be qualified for benefits. And so we're working on some of that information. But other than that, I think it was all pretty straightforward. The last thing I want to touch on in my comments, we came out of last meeting making some commitments in terms of pharmacy work, which we are working on. The 2-week turn from the last meeting to this meeting was a bit quick for us to be able to bring you back meaningful work, but we expect to be able to do that at the next meeting. We did have one in the area of pharmacy, one interesting event last week that heard for the first time. Looked at a couple of drugs to consider where to place them on the prioritized list in terms, particularly in relation to evidence about their cost and or effectiveness. Kind of a demonstration of how challenging those kinds of decisions can be in the face of very active and compelling stakeholders, parents. In this case, and so they deferred. They made action on one drug, a corticosteroid, that evidence found wasn't any more effective than other drugs that are available at 1/1000th the cost of the drug that was identified. The other drug they deferred action until a later time. So more to come on that. With that, I'd be happy to answer questions anyone's got. That's all I got.
I have one.
Could I just ask, I'm a relative newcomer.
Me too.
If
Sure,
I
you can
recall
claim that
correctly,
status.
DCBS plays a role in evaluating the CCOs.
In a couple of cases where a CCO is an insurance company, there is a direct safety and soundness role for DCBS. Moreover, about a year and a half ago, the two agencies formed a healthcare finance coordinating council, which meets monthly to discuss issues of interest in the DCBS regulated community and the OHA contracted community, to make sure that the right hand and the left hand know what's going on, and that if we've got issues that came a little bit out of the Trillium transaction, but especially out of some of the events that MOTA went through at the time, where there's crossover with PEB and OEB, and as well as their involvement with EOCCO and those kinds of things. So we try to coordinate the work across the agencies, but there are only a couple that are actual crossover of regulatory authority.
Okay. So the role of DCBS in the CCO evaluation, contracting, et cetera, is modest.
That's correct.
Yeah.
Yeah, the explicit legal authority.
I think there was a desire, at the time, not knowing how the CCOs would ultimately be formed, to be able to make sure that they weren't sort of duplicating some of the financial regulation piece, but at the end of the day, there's only been a couple that actually are licensed insurers as well. So hasn't been as big of
one
an issue.
CCO owns an insurance company. That's a little bit of a slightly different wrinkle, and then those kind of things play out. And we have tried to work through this coordinating council to harmonize is probably too strong a word, but try to make sure we're looking at things the same way and trying to have some degree of consistency and approach across the two agencies where there are those overlaps.
Yeah. I mean, for me, like, as I read the governor's letter from just a few days ago, I mean, her emphasis, as it should be, I think, is on costs and the importance of the CCOs in bending the cost curve. And, I was just at a meeting in D.C. where one of the speakers presented evidence on, so have ACOs bent the cost curve? No. Has pay for performance bent the cost curve? No. Has, risk pooling bent the cost curve? No. But the cost curve has been bent here. How has it been bent? I think that's really crucial to know. And again, I'm a newbie. Maybe we know that, but as I explore the documents I'm running into, and I talk to folks, how those costs have been bent isn't easy to figure out. And
No, that's right, and I think as important, looking at cost driving pressures going forward, what are the most effective tactics and
That's right.
strategies to continue to bend the cost curve or to keep it from unbending? I think maybe equally as effective a way of thinking of that. And when I was at DCBS Pharmaceuticals, tracking with our conversation last time, was an active conversation there as well. At DCBS, the challenge is the agency's an insurance company regulator and has imperfect, at best, tools to reach through the insurance companies to the drivers of the cost of the underlying treatment. But that was some stuff that we were trying to look at, and the legislature had some interest in doing some really aggressive things around positioning that agency to do price regulation on pharmaceuticals and those kinds of things. But I think both agencies have got a strong interest in how do we manage the cost drivers to keep bending that cost curve.
Right. I mean, one of my concerns is I'm all for focusing on drugs, but it's equally important, I think, well, what about hospitals? What about doctors? What about price versus utilization? What about administrative costs? And then, I mean, frankly, a big issue for me, I mean, when I worked for the Blues, a huge issue was always selection. And it gets back, I mean, I learned that the claim system is very important, but the membership system is incredibly important.
Yep.
When are people coming in? How are they coming in? Where are they being attributed to? Um, You know, that's where all kinds of selection things can occur. And sometimes you can have a very profitable operation that did nothing about hospital, pharmacy, or physician costs, and did well because it was the unwitting benefactor of a number of membership decisions. So,
Yeah, I think that's right.
I mean, I feel a responsibility that when we're saying in our state we've done something to bend the cost curve, that we really have. That the cost curve hasn't been bent because of, insurance issues that really didn't involve any fundamental change in the way care was provided.
Yeah, I'm probably the last person in the room who should opine on this, but my gut would tell me that the fact that we've been at this for better than 25 years as a state on these issues and really well ahead of the Affordable Care Act and a lot of the national investments and strategies and discussions that have been going on probably has a lot to do with that. I think some of these efforts are the kind of thing that take a long time to bear fruit, and that we are bearing fruit based on a continuous strategy, a group of strategies around these issues.
We'll get some more opportunity to talk about this potentially in the metrics conversation, but definitely in the CCO 2.0 conversation as well, which is where we'll discuss a little bit more the letter that John referenced from the governor, which is a letter to the Health Policy Board asking us to continue to play a role in articulating what that system should look like moving forward. So more on that later on in the meeting. I had one other question for you, Director Allen. Last week, the feds neglected to fund or both the Children's Health, the CHIP plan, and then the community health clinics moving forward. I know that there's time between the when that begins to critically affect those systems and the opportunity for the feds to fix that problem, but it'd be helpful, if not today, to at some point soon get a sense from your system about kind of what the implications might be.
I could talk about that right now
That'd be great.
if you'd like. So we have cash on hand that will fund the CHIP program through somewhere between the end of October and the middle of November. In ordinary years, CMS reallocates unspent money from other states to us, and that if that happens as it ordinarily does, and at the level that it ordinarily does, that would get us through about the end of the year. I'm uncomfortable as we currently sit talking about things happening as they ordinarily do in Washington, because I'm not sure what that means right now. But we haven't heard any reason to believe that that reallocation wouldn't happen. That's still, so that provides a period of time for Congress to do what everyone says is non-controversial that they're going to do, and it's a matter of time. And if they do that, then we kind of go merrily along. The question has been, at what point should we be notifying recipients that there may be a change? And we're really hesitant to want to do that because if this is in fact non-controversial and they're going to do it and do it in a way that doesn't impact us from a timing standpoint, you're adding needless fear and instability into the lives of people who frankly just don't need that. And to communicate that there's going to be a change and then communicate, well, there's not going to be a change after all, is awfully complicated, and not for us, but for the recipients of that message. Challenge for us is if they for some reason don't end up reauthorizing CHIP, there are a couple of significant problems. What really happens is we ratchet the federal match from the current 98% down to 75%, and that has a net financial impact on us of about $72 million per year. And that's a $72 million problem that there are a variety of ways to solve, all of which probably require the legislature to engage, either to somehow plug that gap if that's possible, or make decisions about how we would cut that spending from the program. They don't meet until February, and we're out of money at the end of the year. And so there's a gap in there where we will end up needing to make some kind of enrollment decisions as the only tool we've really got available to us to try to deal with that. Now, like I say, We're not getting any kind of indications from our staff in DC and others that there's a substantive, someone's arguing they shouldn't do it. There's lots of discussion about for how long and those kind of things, and but it's a matter of when. So before the end of the year, if it's not been done yet, we will at some point need to take some kind of notification action. But I'm hopeful that we'll avoid that. Jeremy, do you want to add anything on that front?
No, I mean, I think it's a conversation that seems to change a little bit every day. We hear a little bit something slightly different in terms of timing. You know, every day it feels like out of DC from, well, let maybe come together as part of a larger budget package at the end of the year to there's actually two hearings this week on it. So I think it's kind of moment by moment in terms of figuring out what the path is, but we have heard pretty consistently that there's bipartisan support. The question seems to be around the timing and how is it a 2-year extension, is it a 1-year extension, is it a 5-year extension? But we're not unlike most other states in terms of, I think, anxiety of watching this closely and knowing that we're running up against money running out. But I think, I would echo Pat's comments around the fear of making sure we don't add anxiety or confusion unnecessarily. And so I think that's one of the things we're trying to kind of balance.
Yeah, given that uncertainty and the immediacy of it, it just seems we should, I think, stay close on that, both in terms of if there's a value at any point in kind of providing an additional level of clarity about the importance of the CHIP program for our federal delegation. I think that would be something that we ought to consider as a board if there's value in it. And then as I hopefully we are meeting in a month and we're merrily on our way, as you said. But if we're not at that point, it also feels like there's some, it's important for us to talk about this from a policy perspective. I think about the MAC letter that we received last month and the framing that they did to really, I think, in potential times of financial uncertainty or losing resources from the feds, being intentional about maximizing our ability to manage that with the least amount of impact on individuals that are covered, either in terms of their benefits and or in terms of who's covered. And it sounds like, if things don't go well, and which they could just because of politics, even if everybody agrees, that there's some hard decisions between here and February at least.
Yeah, I think if this is unresolved at the time of the November meeting, I think we'd want to have on the agenda some discussion of what our contingency thoughts are.
Great, thank you. And then I know that the community health clinics are kind of a little bit separate, but I also know that that has huge implications for FQHCs in the state as they think about their budgets as well. And so I think it's another place where, as a policy board, if people have a sense of where and if there's an opportunity for us to take action that could be productive, that we ought to be willing to do that. And Brenda, I don't know if you have any more.
Oh, I'd love the opportunity to work with you, maybe offline, to talk about a way that we could advocate on supportive health centers for sure.
Great.
Yeah.
Well, I wonder if waiting until our November meeting is waiting too
Yeah, it's
long
too long.
for making
It's
even
like
just
this
a
week, yeah.
support letter or a letter of concern or something to Wyden and Walden.
On both fronts.
Mhm.
On both, yeah. The markups are happening this week, so it'd be helpful, maybe even today we could talk.
Yeah.
Yeah.
That's a great idea.
Can I just ask, the community clinic thing is separate from CHIP?
Mhm.
It's not linked to CHIP?
Right.
So is it a HRSA? What?
It's just
Both expired at the same time.
Yeah, it just has to do with funding expiring at the end of the federal fiscal year on
Okay.
September 3rd. Both of those are items on a long list of things that basically haven't gotten extended by Congress yet.
And so is that an item in the HRSA budget, or?
I don't know.
Whose
I don't know.
budget is it
I don't know
in?
where it sits in the federal budget. I do know that the funding flows straight from the federal government to the clinic, so it's not funding that flows through OHA, but it's the funding for the original. It's really the original FQHC funding, so it goes to a whole series of things, and Brenda may know more, but
Yeah.
it goes to capital, goes to grants, to the community clinics.
Yeah, it flows through HRSA, but the other piece that I think we should acknowledge that's at risk is the National Health Service Corps. which is a loan repayment program that our state benefits tremendously in terms of workforce development. That's also sunsetting or has sunset at the,
Yeah.
September 30 time.
I also think that the end to the teen pregnancy program is a huge issue as well, if we're going to talk about holistic care for our state. So there are all of these federal issues that threaten the stability of our healthcare system in our state and the coverage of every single life in our state. And I feel like, how do we send sort of a regular kind of update on these, either at this board meeting or just that sort of reiterate our principles of, we want 100% coverage of needed services in our state that are quality, affordable healthcare, and that the cuts to these programs or that, because I just think we're going to keep going down this path, that even if they renew the budget, then there's going to be the Medicaid cuts, then there's going to be block granting, then there's going to be an end, the perennial conversation about defunding Planned Parenthood or whatever those things are. And those have real impacts on how we are delivering care. So maybe there's, I don't know, how we send a regular message about that.
I don't know, we could certainly work maybe offline and try to put something together in terms of a letter. I'm not sure.
Yeah, I think there's two things. One is the notion of a letter, and then the other one is just kind of a regular ability to have a clear sense of what the implications are of either federal action or inaction. So, and given this conversation, if there's a way to think about that, about health broadly and not just what's under the purview of the health authority. So that would be maybe different than the kind of what you all are getting from your folks you're working with in DC at this point.
I think also, in addition to letters and those kinds of things, I think right now the really important lever are direct relationships you all have, particularly with Congressman Walden, who has influence on the process, and I mean, candidly, a lot of the rest of our delegation doesn't have as much influence by far, and so I think that's one to be thoughtful about and think about how, just last week we learned that he thought everything was fine until the end of the year, sort of for sure, and wasn't aware of the distinction of only if CMS rolls out more money. I think part of why things are happening now is because more members of Congress have figured out that their states actually do run out of money really fast. But having him and his staff be aware of the impacts on the ground, I think is super important.
Can you just clarify, in the case of CHIP, it's an issue, it sounds like, of a different match rate. If CHIP goes, well, then those children go to a lower match rate, but they're still federal funds. For the FQHCs and community
Right,
clinics,
it is a different issue, that's right.
there is no default.
Right.
It's gone, or it's a lot less, and there's no federal match or incentives or anything of that sort, right?
Right, but my understanding is that issue is also a timing issue. It's not a substantive issue of is it going to happen or not. So instead of being a state cash flow issue, it ends up being an each individual provider cash flow issue, which is all over the map.
And how many of them are in our state? 52?
Actually,
I
off the
don't
top of my
answer
head.
that.
I
Yeah.
don't know.
A bunch.
Bunch.
And they're all in CCOs, too.
Right.
Right, so to some degree, that it could make CCO shaky.
It phrased the whole fabric, that's right.
It does indeed.
Yeah.
So as a policy board, it sounds like we want to consider some immediate action in terms of communicating with the federal delegation. And then to Pat's point, if there's anybody who has a more direct relationship with Congressman Walden and his staff, that's worth reiterating the urgency of getting some solutions on these issues.
So we're happy to take a stab at a letter on your behalf and can float it around in terms of advocating on the importance of stability in all these areas. And then I think maybe at the November board meeting can give a more substantive date if doesn't seem like there's a path towards extending what a little deeper analysis on what the impact of those are at that time.
That'd be great.
Hopefully at that point you can tell us what it means to be moving merrily along.
Right.
And if not, then whatever time we need.
Okay.
Great. Thank you for the update and for fielding the questions.
I should note too, the Medicaid Advisory Committee also put together a letter in support of CHIP as well, so we'll send that around.
Okay, great. Good to know. committee liaisons and consult updates, are there, I think there were only a couple committees that met in between. We're going to hear in a moment from Quality Metrics, so we can bypass a specific update there. Public Health?
Yes.
Great.
The Public Health Advisory Board met and on the update of the accountability measures, which I assume we'll talk about today. The Public Health Advisory Board adopted 8 health outcomes for the government public health system. We're working on process measures currently. We also made a recommendation to the Oregon Health Policy Board that the Health Plan Quality Metrics Committee create a mechanism for the FAB to introduce metrics that promote upstream population health and social determinants of health for consideration and timelines, so there could be a back and forth. And I assume we'll talk about that later today. We also reviewed findings from the Tobacco Prevention Competitive Grant Evaluation. The FAB Incentives and Funding Subcommittee is working in collaboration with the Tobacco Reduction Advisory Committee on recommendations on how to minimize disruptions in tobacco prevention programming with a $3.6 million loss in the Tobacco Master Settlement Agreement for 2017-19 biennium. The full FAB will review the final budget recommendations at the next meeting in accordance with House Bill 5006. FAB also adopted guiding principles for healthcare and public health collaboration. There are languages in the document that were revised. All the no significant changes in the document. Most of them were editorial and language. Questions?
Any questions about FAB? I do think that we can talk about
Metrics.
the metrics
Yeah.
conversation, that recommendation. Great. Okay. Hi, Talk.
Sure. Thank you for the last meeting approving their strategic plan, and they have made the alterations that, recommendations that the board suggested, and that has now been finalized. Their upcoming meeting, they're meeting jointly with, or having a conversation with Quality Metrics Committee, whom we have a presentation from today, and that, on the High Talk side, their alignment in work is around the utilization of IT in provider clinics and how to reduce practitioner burden of reporting and form filling, and how to use IT to kind of narrow some of that workload for practitioners. And then they're also exploring the alternative payment models, and for the High Talk portion of that type of research is kind of figuring out how IT plays a role in developing those models and how it creates functionality, efficiencies, and effectiveness, and doing research on what other types of support High Talk can provide either for consumers or practitioners in that role of the payment methodologies and the different models. So that's what they're focusing on next. Thank you.
Sounds really exciting.
We did, the High Talk, or the Office of Health IT actually did make some changes to the strategic plan with the board's recommendations from last meeting. So I don't know if those have gotten sent around, but we were planning to send those around. So we'll make sure you get those to reflect the feedback around equity and feedback around the importance of sort of consumer engagement in the work. So.
Excellent. Thank you.
Yeah, just a comment. I have a conflict of interest because I'm involved in Open Notes, and Open Notes is easy access to clinical notes. The research we've done and others have done, there's a subset of administrative stuff that's called administrative stuff, but it's about the relationship between the physician and patient. And one of the growing concerns we have is that many physicians see what they do in terms of filling out their chart is administrative. It's not. When patients see that, it really affects their relationship with their physician, almost always positively. So a subset, I think, of the information that technology is making possible is an incredible part of the patient-physician relationship. And somehow I think more of my physician colleagues need to appreciate, what you write and what people read really is influential. They really trust you. And you're not just riding for a billing code or, a performance metric. You're riding because they're going to read it, and it makes a huge difference. I was talking to a physician in California who was very knowledgeable about tech, and she happens to go to her physician at a different institution than where she's at. And that institution is sharing notes. But her physician tells her, I don't like that, and so I'm not sharing notes. And she says to her, well, I do like it, and I want my notes. And she gets her notes. There's some issues in her notes. There's some errors in her notes. This interplay now is on, and I think it's going to get more and more common. And I think it's going to be a very positive thing eventually, but we're in a tricky transition.
Thanks. We'll hear about behavioral health a little bit later as well. I wanted to just also acknowledge two things. I know that the Equity Committee has not yet met, but their intent is to meet in the second half of October, so we should expect an update from Oscar and from that committee at the November meeting, which will reflect that first meeting and hopefully will give us some sense of how they're thinking about the work plan moving forward. And then Director Allen had mentioned the pharmacy report as something that we'll come back to in the near term. And just wanted to acknowledge that I know that the staff is working to connect with both Dr. Santa and with Felisa to help shape how that information comes back to us. So I think that's a good, it's not a formal liaison role, but it's a good space where we have an opportunity to really ensure that that comes back in a way that makes sense. So thanks for that. I don't think there are any other committee updates. Seeing none, I know the Workforce Committee is meeting, I think later, is meeting tomorrow, so we can expect something from Carla when she comes back as well, or is meeting soon. Great. So we'll move on then to an update on the health plan quality metrics. Dr. Santa, I think you may be ready to introduce our presenters.
Yeah, I am. Well, it's a privilege to introduce the Health Plan Quality Metrics Committee leadership, who's going to report on their activity. Recall, this was a committee created by Senate Bill 440. So interestingly enough, they not only have us and the Health Authority and various other folks inputting to them, but they actually have the law in some form. I'm impressed when I read that and think, oh, that's interesting. So they've been meeting monthly and trying to sort out the pathway to performance metrics that will satisfy a number of needs. And so I think this is a critical area. And so Dr. Dillon and Sean Parkman, welcome to the Oregon Health Policy Board. Go ahead.
All right. I'm not quite sure. Yep, we're working great. Okay. So hi, my name is Kristen Dillon. I'm a family physician. I live in Hood River, in the beautiful Columbia Gorge, which is open for business. So please come see us and bring your wallets. So I was really honored to be able to join this committee. My current work is as the director of the Pacific Source Columbia Gorge Coordinated Care Organization. I'm also still in practice part-time at the Sherman County Clinic in Morrow in Eastern Oregon. And I was volunteered and was chosen to chair the group, which has also been a great joy. It's been great to work with the staff and the committee that was put together. Lot of potential and good folks involved. Sean?
Hi, I'm Sean Parkman. I'm the vice chair of the committee. And another role I play is that I'm vice chair of PEB, Public Employees Benefit Board. There I am there on behalf of SEIU 503. And for my day job, I work in the Public Health Division in the Oregon Health Authority. So a lot of work relating to evaluating the effectiveness of various public health interventions.
All right, so you got materials in your packet that really lays out the background on our committee. I know you have a lot of interest in talking about specifically measures related to health equity, which we're prepared to do today also. So Sean was going to run through quickly some of the background and basics of the sort of underpinning of our group, and then hopefully we'll get into some of the rest of that.
That's right. So our committee was created by Senate Bill 440 as the attempt was a single body to align specific and specify the quality measures that may be used in health plan purchasing. And that covers these following types of metrics. So CCOs, Oregon Health Insurance Marketplace, the OEB, Oregon Educators Benefit Board, and Public Employees Benefit Board, PEB. So those are the entities that that this committee's work affects. And basically the idea is that the metrics that this committee approves can be selected by those groups. In other words, they can be metrics that are applied to these groups. But no metrics can be chosen to affect these groups that have not been approved by this committee. So in other words, they don't have to choose all of them that our committee does, but they can't choose any that our committee didn't, if that makes sense.
No ordering off the menu, and you're creating a menu.
That's
No
a good way to put it.
substitutions, yeah.
Exactly. So this hopefully is familiar to you. So I think our committee is affecting these various elements in your overall plan. CCO engagement, accountability, transparency, value-based approaches, a multiplier alignment, all these things come up in our committee discussions. It's a lot of people that this potentially affects, right? So coordinating care organizations, of course, almost 1 million, but you can see here PEB, 140, between OEB and PEB, more or less 150 each. The exchange, the marketplace, another 150. So there's a lot of impact that potentially that these alignments are, these decisions will affect. So the specific charge of the committee, Senate Bill 440 specifies that the committee prioritize measures adopted by other state and national organizations, measures that rely on existing data systems, and measures that can be reported in a timely manner. So there's a heavy deference to existing measures that have been tried and true. The committee articulated additional criteria to guide its own work, that they represent an array of services that affect health, represent the diversity of patients enrolled in health plans, be collectively parsimonious, which is to say is, a set of limited measures, and include measures with transformative potential. Christine, you wanna?
Can I ask a quick question?
Please.
Just to, as I'm trying to absorb all of this, can you give me a simple and clear differing definition of metric and measure?
I use the two words interchangeably.
Yeah.
Sean?
No, I think
You're the public
committee
health
does.
guy. Okay, good.
So the committee, one of the things that the committee's sort of challenged with is metrics for what purpose, right? So, on the one hand, there is an intention that a lot of these metrics are being used for incentives and attached to various payments. But the committee itself is not in the role of telling health plans or other payers, any kind of payer, use these specifically for incentives and value-based payments and this sort of thing. That's still up to the payers. It's just setting the menu, and so kind of the the division between measures, metrics, incentives versus aspirational measures, that sort of thing, is a bit agnostic on the committee side. So there hasn't really been a clear division between those 2 points.
So on the slide prior to the one on the screen, on the upper section, the 3 bullets, when it talks about measures adopted from other national organizations, what I'm trying to understand are those actual metrics that we're incorporating into our system, or is the term measures some kind of broadband scooping scope of a handful of metrics? Is the words interchangeable, or do they have different meanings?
The committee's using them interchangeably. So I think what's meant is metrics. So
Okay.
Yeah.
Yeah, so the idea is it's defined about what's being measured, there's a numerator, there's a denominator, there's a population under consideration. We're going all the way down to that level of detail, because it's crucial that that level of detail the alignment go all the way down to that level of detail. Absolutely.
Thank you.
Sure.
Just to chime in very quickly, a little more detail. I'm Margaret Smith, ESA with the Oregon Health Authority. I'm staff to the committee. And specifically with regard to the way that the word measures is referred to in the legislation around those nationally and state recognized measures, they're typically referring to well-known measures that have been validated, in use, and benchmarked is typically how we think of them. But yeah, absolutely correct that this particular committee hasn't gotten into a really fine distinction between measure and metric.
Can I just clarify, because this is an important question. So you all do define the numerator, the denominator, the population. And so the folks who use this don't have the ability to change any of those.
That's currently the direction that our work is going, because the committee's been crystal clear that having a measure that's conceptually the same with underlying math that's different is a problem.
Right.
Yeah, and that really
And
was
that's
the
outlined in
intent
the
of the bill, was to,
legislation.
you know, if, I worked on this like several hats ago, but, you know, was to make sure that if we're measuring diabetes, for instance, that PEB isn't doing it in a slightly different way than
Right.
OHB, in a slightly different way than the CCOs, that, you know, maybe eventually you get to a spot where you've got a core set of metrics across those programs, but sort of a first step is at least making sure that we aren't measuring things different and,
Yeah.
um,
So I mean, so you all determine the menu, but you determine the math.
Sure.
And the other math issue is the threshold for meeting.
Right.
You all determine that, or the payer? So
The
in
payer.
other words, one payer could say, our threshold is 90th percentile
Right.
of the national performance. Another payer could say 50th percentile.
That's right.
So that math,
right.
the payer,
Still has control over
the
setting
three
the
payers
targets.
or four payers
That's right.
could choose different threshold. They
They
have to
could-
use
they-
the same methodology.
That's right.
Threshold methodology. So
Right.
threshold is the other issue.
So yeah, right. So some target for Medicaid, for example, might be, conceptually, it might make sense to have a different target for PEB, which, you know, includes a very different type of population. So you might not want to set those two things at the exact same target, because perhaps it would be easier for PEB to achieve it, depending on the measure. So yeah, that power is still with the payers. But yeah, exactly, our understanding is that where this was coming from is that, you know, as these metrics are experienced by the actual practices or the organizations that are needing to measure, you might have diabetes being asked of the same clinic or practice or organization, say 3 or 4 different times, with slightly different iterations, which is experienced as if they're 4 different things, because you have to have a different system to measure them a different way. And so the idea is, one of the ideas of the legislation, as I understand it, was to unify those measures so that all the payers and all the requirements being asked of the clinic, they're being asked to measure diabetes once in the same way by by these different payers so that they don't have to build multiple systems to answer the same question.
Yeah. I don't want to get too far in the weeds, but just one more question beyond that. I mean, sometimes the thresholds are referred to the cut lines. You know, above, you get the reward, below, you don't.
That's right.
So do you all, so you all are essentially setting, the cut lines can be set by the payers.
Right.
What about risk adjusters and standard deviation? Because, you know, in this world, what you'll have is, so somebody is right below the cut line. They say, well, wait a minute, our result is within one standard deviation. So statistically, you know, you have a cut line, but then you have a boundary of uncertainty. Does the payer decide about that boundary of uncertainty? Do they decide about the risk adjuster, or do you?
Particularly the statistical issue is something I'm well aware of, working for one of the smallest CCOs in the state.
Right.
And so there is actually some language around statistical significance or reliability in the legislature, and our intention is to interpret that for us to be able to make recommendations around population sizes or other factors which may make the measure statistically unreliable or might be a consideration in terms of how it's applied. Because there is, even looking at some of the stuff I've been looking at recently, we've not been in the habit in Oregon of showing the error bar a whole lot when we break things down or do stuff, and I think that's really important when you get down to dozens or hundreds of people, even across the state, in some of the reporting that we've done.
Sorry, I'm moving us back. So some of this has to do with the first three bullets, right? Some of the national organizations that come up with these metrics have recommendations around that. Otherwise, they can be, the measures have to rely on existing data systems to produce reliable estimates. And so that's something that the committee wrestles with a lot. 'Cause there's been various measures that come up, boy, this is really important, but you know, the committee might feel that it's unlikely that enough of those organizations that that fall under this committee could produce it reliably enough. And so, you know, that's another factor that's explicitly part of the committee discussion.
So this is the committee membership, which was established in the legislation. Great group, lots of good expertise in the room. The one gap is there's not an oral health or dental care provider called out in this legislation. We have had some participation from people with that expertise, but oral health is a major health issue for Oregon, and I worry that we not perpetuate that by forgetting to include it in our measurement. So it's well on our radar. We're doing our best to include, but I just think it's important to call out that sort of, to some extent, we forgot dental again.
Is the membership so defined that the group could not opt to add if they so choose?
Yes, it is.
It's defined in the legislation. So we've, like I said, Dr. Schwartz from OHSU has been participating. There are dental and oral health experts on like the metrics and scoring committee, but it's not something that was officially part of this body. I just think it's really important as we're talking about health that we've got to remember oral health dental providers when we do that.
And obviously, we didn't need to change the legislation to actually change the official membership, but if there's an obstacle you're running up against in terms of expertise, certainly please let us know. We can get the right experts there to help you guys.
Excellent, thanks.
The other thing we can talk about in a little bit too, Carla McKelvey, Dr. McKelvey, who's not here today, wanted me to mention as well, just some wanted to make sure that the committee is adequately able to get perspective from consumers. And I know that there's 2 seats there. It's a little unclear to me who, I can see one of those, but I can't see the other in looking at the membership. But I wonder if with these kinds of questions, whether there might be some mechanism for engaging a group or groups as a kind of parallel ad hoc advisory group as you're working through this process as well. Not to unnecessarily add another step, because I know you're already doing quite a bit of engagement of the other committees that we've got, but we're thinking about in terms of those perspectives and voices which may not be adequately reflected on the committee so far.
And maybe this is a good time to introduce the discussion of the FAB where there's a motion that was unanimously approved to make a recommendation to create some type of dialogue between FAB and this committee, because not only, and Ellie Schwartz is on the FAB, which is helpful, but to make sure that these metrics are looking at upstream determinants, and so as another way to sort of improve health outcomes and bend the curve, cost curve.
Absolutely, absolutely. So on the theory that if you don't know where you're going, you have a smaller chance of ending up somewhere good, the committee did draft a vision and mission statement for our work. We very much see our work as aligning with the ultimate goal of having a healthier state, and are trying to remember that as we do what can be work hard, long on trees and a little short on forests. So the near-term approach, I mean, we're basically cleaning the garage. We're going through everything that's currently in use in the state, working with our consultants, trying to figure out where does stuff align, what's going on. Prioritizing the measures we think are worth keeping. We're being very cautious about eliminating measures that are currently in use now, because we know the impacts our work can have. But in some cases, I could see the committee signaling that there's some reasons that we could see for retiring certain measures and perhaps going in other directions.
That you haven't reached that point in the conversation yet, but you can see that in the future.
Yeah, I can. I mean, there's been, honestly, the childhood obesity measure that Metrics and Scoring just adopted caused a lot of debate in our committee, enough that we ended up tabling it for later discussion, because there's a lot of concern that the evidence, the measure is measuring a behavior done by a clinician with their patient that does not have evidence that it actually leads to addressing the problem of childhood obesity. And so why are we measuring something if we don't have a good driver diagram that shows it actually gets us where we want to go? And so that's sort of the little axle we got wound around on that one.
I mean, some of these committees, the measurement is submitting your data. So
Right.
that maybe could be eliminated at some point.
Right. And so our near-term work is to try to accomplish a draft aligned measure set. Like I said, finish cleaning the garage, try to get the measures currently in use lined up, get that surrounded by early 2018 so that it can help inform contracting that would then be put into place for sort of the 2019 year. Have a pretty broad comment process, which I think is another place to include the patient and community voice. Patients and people from the community have been pretty much absent from the development of metrics in general. What people value, what they want, has not been a huge piece of the metrics that have been chosen and put into use. They tend to be driven by sort of clinical and biomedical considerations. Totally welcome to go there. It is, again, sort of relatively uncharted territory. And then to establish an ongoing process for some annual review and maintenance of that sort of basic set that looks a lot like the as-built. Yeah.
Can I ask a question for the staff about if we have a calendar of the contract alignments? Because I think the CCO contract, we'll have a discussion about that today, but then the PEB is on a different alignment maybe than the OWEB is on, and then the private market is on. So if we're trying to line these up, like, is there a phase-in plan for when the menu starts, when you get your menu?
Sure, sure. So the idea would be that there would be a menu available. We're aiming for spring of 18, and that each program would implement it into their next possible contracting cycle. So like for OEP, their plan year is an October 1 start.
Yeah.
So it's a little different than PEB and CCOs, and most plans generally are on a calendar year. So there are some differences in the programs in terms of what their actual calendar is. The impact of that would be that maybe, one for a program would start a few months earlier or a few months later with the measures, depending on what their contracting cycle looks like.
Okay, I think I'm a little bit confused about that, because I think that the timeline to decide if you're going to participate in the exchange is earlier than that spring period. You then then you say to DCBS, yes, we're going to participate in the exchange. Then DCBS hands you the set of metrics. You can't then pull out of the exchange after you just said it. If we could just get a calendar of the timeline of like when we think this menu actually gets to its full implementation based on the contracting cycles, that would be super helpful.
And that'd that'd be really helpful for us as we look at that annual maintenance, to know what's sort of the deadline for getting the refined set out every year so that it can cascade through the contracting cycles.
And then I think just to go back, because at some point, all of this is going to come back to the board. We're going to see progress on these, hopefully. But if everybody started at different times, what their progress is will probably vary wildly.
Yep. All right, so looking towards the longer term, there's tension within the group, in part related to the legislative constraints and charge that was given to us, and concerns that the current science around metrics for healthcare and health neglect some really, really important things, yet we were charged with prioritizing measures that are validated and currently in use. So we've just sort of acknowledged that that's our next phase. After we clean the garage, I don't know what we're going to do, pour a new driveway. So this is sort of the next phase of that. And I don't know if that means going back and asking for a revised charge from the legislature, quite what happens there. But the committee's well aware of the limitations of our charge and what that may mean.
So when you speak about next phase, do you have a time horizon when you're thinking about this longer-term picture?
We
Well-
don't at this point. I mean, go ahead, Sean.
Yeah, I mean, the presumption, so in order to have a measure set done by basically December, so that there's enough time for public comment in order to have something finalized in spring 2018, that's a pretty, from the number of metrics that we're having to run through, is a pretty oppressive timeline, really. So I think the presumption is that once that measure set is finalized in spring, then that sort of resets the clock for the next year. At which point, I think that will be the time to really have the opportunity to delve into some of these issues about involving negotiations or discussions, I should say, with the legislature as well. It's like, if we want transformational measures, if we want transformational potential, that may not lie in existing measures that, that are being used everywhere else in the nation. So, and also, how do we deal with social determinants of health? Some of those discussions we're having now, but the timeline is not conducive to being able to develop wholesale new things in this particular time. I think we're hard pressed just to get through the measures that exist currently. So I think that, to answer your question, I think the next year, so starting basically as soon as it's finalized for this year, then we'll have to start moving into this potential of new measures. Plus, that gives some of the subcommittees more time to work out some of the kinks and some of the innovative measures that they've been working on, metrics and scoring, for example. So,
Yeah.
I see this as a really important tension, and historically, because it really stifles innovation,
Yeah.
stifles moving upstream, stifles bending the cost curve, which are all in our all interests. Historically, what has been the role of the Oregon Health Policy Board in feeding back to the legislature to make tweaks or suggest guidance as that maybe what they passed was meant well, but needs refinement? Is there a mechanism?
I think it's us. I mean, I think it's as staff to the board. Certainly, if there's tweaks that need to happen, then certainly we're here to help with that. I think the approach on this, I think, was sort of a walk before you run approach. There seemed to be a lot of metrics conversations happening in a lot of different tables, and not a lot of coordination, or at least not feeling to stakeholders like there was a lot of coordination. And I think that the step one was, well, let's make sure let's start by getting one table and sort of driving the conversation there, and then figure out kind of, okay, longer term, where do we want to go with all of this? But at least make sure that folks kind of we started to coordinate and not have 6 different metrics tables, trying to set different types of metrics for different markets.
I understand that if you have to start somewhere, you want to start with success.
Right.
But then, does that feedback have to wait till the next legislative session in order to?
The
become
legislation
incorporated?
actually doesn't preclude additional or transformative metrics. It actually just says that they have to be prioritized
Yeah.
to set the framework. So you don't have to go back to the legislature actually to do metrics around social determinants of health or any transformative metric. You just have to set the first set and then move forward from there.
Yeah, and I think it was very intentional that the committee was established as a committee of the Health Policy Board to make sure that it's synced back up with the work that the board's doing.
Yeah, I mean, I think, given that fact, that this is very clearly a committee of the Health Policy Board, I think it's our responsibility to work with the committee to identify where there are barriers or challenges in that regard. And if those are barriers that require legislative action, I think we can and should immediately communicate that back to the legislative body. And then I also think we ought to figure out where we can actually extend the purview and support the work that the committee is doing. So as we think, so specifically as we think about this conversation
Yeah.
and your kind of check-in with the policy board, here's where we're at, I think being really, we have an opportunity to be explicit about some of our expectations, hopes for the work you're doing, and you have an opportunity to come back to us and tell us kind of how that's happening. So to that end, where there are places where you feel like the existing mandate is limiting the committee's ability to actually do the work that we need to have happen in order to meet your mission, I think identifying those specifically and being explicit with us about what those limitations are so that we can then take action to be able to support how we can address those.
I like the definition of prioritize, try it first, and then allows you to try something later, something different later.
And thanks, even just hearing from you about that your goals align with ours. If we're going to start just sort of interpreting and trying to understand the nuance in some of this, it's good to know that we're aligned in terms of where we're going.
I think having, just real quick, I think I really appreciate the frame of near term and longer term. I'm looking for some space in the mid section, quite honestly. And I'm particularly interested in the tension around the social determinants around health equities. We have been having the conversations around disparities for so long in this state, and I'm concerned that we're just continuing to kick the can down the road more. So my preference in terms of hopefully reflecting, I know some of the board's conversations have been to think about bringing those issues in a more timely way.
Sure.
And just to be clear, so as I heard you respond to Brenda's question about near term, long term, what I thought I heard is, in effect, near term describes actions and deliverables that will be completed by spring of 2018 for adoption, and that then the longer term, in effect, are then actions and deliverables that you will be working on post-spring 2018. Is that right?
Yeah.
That's right.
I can show, so this is the work plan, which hopefully we can move through pretty quickly. I do think there's some risk that come March, we will not have a full measure set. I think my goal, if that's the case, would be to have a complete measure set in some areas. Complete for preventive services, complete for hospital, complete for behavioral health, with the caveat that we've not had anything to say about chronic disease measures, and we want to let the OHA and their contracting do what they need to do. Like I said, there's a lot of measures, and there's been some pretty time-consuming but very thoughtful debate on a number of them, and I don't see any way to push through that, given that there's just a lot to process. So I think there's a chance it will be complete in some areas, and our goal then would be simply to sort of not make a statement on the other areas so that we're not constraining the plans, and that we have a complete set, sometime later in the year for implementation.
Sorry.
Yeah, when I listen, I think what's happening here is there's going to be some measures that will be just fine for transactional stuff, money, that the CCOs and all will be willing to agree, okay, this is predictable enough and we understand this enough and consistent enough that we'll sign a contract with this in it. There will be some that no one would blame them if they said, wait, this is transformative, it's innovative, we're happy to work on this, but we're a little bit worried about attaching money to it. The other variable is science and what you mean by science. when I was at Consumer Reports, if we would have been inhibited by NQF, we would have never done anything. When we published the first, national results on central line infections, that was using a methodology that we worked on for a year with CDC. And, I see that dynamic here. I mean, you have a very, reputable science source, the public health folks. So that I think you could do transformational or innovative measures and satisfy science concerns without, having to satisfy the whole country's science concerns. Then the question is whether those at some point pass into being transactional.
Just wanted to acknowledge to, your point earlier about the distinction between the committee's work and then the fact that payers are in effect both setting the thresholds and potentially are then articulating how those measures play out in relationship to their contracts and paying or payment. It's interesting to think, so if we look at the CCO system, right, there is both an opportunity for transactional and transformational measures right now. The system is built in a way that it's not an all or nothing, right? So you've got both the fact that you have, you don't have to meet all of the measures and that it's not related to all your money. So I just think that as we think about this, and if you run up against this space where the list isn't complete because it can't be for XYZ reasons, how the committee still articulates provides some information about what's not completed as a mechanism to be able to be, to like, it's not putting that away, but actually that information could still potentially be incorporated too. So this difference between what the committee's work is and then how that gets used in each of the systems, there's still some play there, I think.
Okay,
worth
and that's
paying
helpful.
attention
That, go ahead. You
Yeah.
want to-
I'm also not sure that you couldn't have a transactional measure. But within that transactional measure, you might be able to demonstrate whether there's equity going on. I mean, let's say your measure is control of high blood pressure. And let's say the population in general is at 50 percentile, so there's a lot of room for improvement. What's the gender, racial, and other mix of the 50% that are treated successfully? And then what's the racial or gender mix of the next increment? And what does it say if, the next increment is all middle and upper income folks who are white? That's the lowest hanging fruit. That's not good. So the transactional measure is where the money is going, doesn't get at that, but you could possibly measure something related to equity within that without everybody going nuts about the burden of collecting more information.
I hear you on that. I feel like there's a bigger discussion to be had about that, because I think in the CCOs, and I'm just speaking for the CCOs, not this work, it is time that we begin to move transactional measures around equity within the CCOs. We have seen great improvements for the majority population in our state, which is Caucasian, white people, however they identify. And we have yet to see some of those same improvements for people of color. And Medicaid is disproportionately, has a higher number of people of color. So when we come back around the CCO metrics, I think those transactional measures around equity should be a clear part of that. And I think, we'll look at the other, these other folks once we get the menu together and start moving forward. But at some point, we have to stop saying that we actually care about equity and start paying for it, because clearly that's what people respond to.
So I think, I understand, and John had the all the thinking around health equity, what we're trying to do. And I'm having some tension around this idea of we need an equity measure, because it feels like it's pretty early in the steps. I brought this example. This is a measure, right? This is a tape measure. You want to measure, there's a measure. Here's a measure, that's a measuring cup. You want to measure, here's a measure. Question is, what are you going to do? What do you want to do with the measure? If you want to make pancakes, this is probably a good thing to do. And in fact, if I knew you wanted to make pancakes, I'd give you that measure too, because you're going to need both of those to be able to do it. If you're going to cut the glass for a window, this is probably the measure you want to use. If it's a window for your house, it'll work. If it's a window for the space shuttle, oops, maybe this isn't the measure. So the fact that you wanted to cut glass wasn't enough information. Measures are only good when you know what the goal is and where you're trying to get with them. I think it's very important as we talk about this to distinguish health equity from health care equity. They're both really important, but we need to be looking at both how are groups who've historically received poorer service receiving health care, or are there differences that we can't explain in how different groups are receiving health care. There's a separate issue, which is how healthy are people in our state, and does the burden of disease fall disproportionately on certain groups or subgroups or regions of people. The first around health care is very much, I think, the work of those of us in healthcare, health measures, health plans. I puzzle a little bit, and I want us to be really thoughtful about, in reaching our goals for the equitable access to health in Oregon, what's the role of all these various entities? And I think we could really use guidance from you, from the Public Health Advisory Board, from some of those folks about what are the issues around health inequities in Oregon, what would the goal look like? And then I think our committee is really well suited to try to respond and do the thinking around what would be the drivers to get to that health equity, and then how do we measure whether or not the drivers are being put into place and whether or not we're getting where we need to go. But I'm very hesitant to go find something that differentiates groups of people for its own purpose without knowing that it's lining up with the ultimate goal.
I want to be really clear, that's not what I'm asking.
Sure.
So I think what we're talking about is a set of metrics now developed that are the clinical metrics and the NQF standards. So the NQF standards say that the mean is X, and every single African American is 20% below the mean. That is poor health care service. And we continue to give people that poor health care service. And in Oregon, we move it to, we're at 80%. But African Americans still say 20% below. That is poor healthcare service. So I feel like of those metrics that we're currently measuring, I think that then Brenda's issue that she raised, and I think all of us agree, is the social determinants of health, right? Which is housing and economic security and all of those things that play into a factor around long-term disease management, right? If you live in a low-income neighborhood next to a freeway, you're more likely to have asthma. The people who live in low-income neighborhoods next to freeways tend to be people of color because they don't have the economic means to move out. That's a different set of measures, and that goes into the more long-term piece. I think the first set, I think the healthcare industry needs to dig real deep, own the mistakes that you have made in the past, the disproportionate quality of care that you have given to people of color, people with disabilities, and the LGBT community, and rise above it to get some equality in those current metrics. That's the instruction I feel like that I'm hoping for, and it seems to me like we better pay for it, because that's what makes you all rise above and recognize those inequalities.
So I hear you, and I do agree that addressing health care inequities is the job of the folks in healthcare, primarily. Intriguingly, you took a little swing at the NQF. They're a fairly conservative group. That said, the National Quality Forum has not authorized sub-analyzing any of their measures by race or ethnicity. Their internal advisory group has made some specific cautions around and like I said, this is a whole body of work that I'm not familiar with. I know they've just released their framework this week around health equity. So again, we're sort of going into uncharted territory in terms of using measures in ways that they sort of weren't defined. And I think it's just going to take some real thoughtful examination of what are the reasons behind that, and being sure that we are learning from the work of others while not perpetuating systems that have not served a lot of people well.
Could I jump in here, just
Yeah.
add something? So I think it seems to me that there's been kind of somewhat two approaches so far in trying to get at equity, and one of them is this health care sort of subdivisions, which is completely legitimate, right? So, for example, just to get a really tangible example, there's just no question that colorectal cancer screening rates are different. So we know that it's just factually true that African Americans are less likely to get screened on time for colorectal cancer, and therefore their mortality rates for colorectal cancer is higher than whites. So that's just true. One of the challenges that the committee has already had, and we haven't gone that far down this route yet, but already there's some indication that this is a challenge, because one of the first things people say is like, yeah, but we're going to have small numbers, and those small numbers, back to the reliability bar, those small numbers are going to, we're talking in some plans, we're talking literally 12 people, 10 people, 17 people, and depending on the plan. And you can't, that's not statistically reliable, because from year to year that could change, that could swing like 40, 50% depending on the people that you have. And so if you tie money to that, the complaint will be, well, that wasn't fair because it was just a matter of like who was there. Now, I don't know if I buy that, but I'm just saying that's a debate.
It's a matter of calling.
That's a small numbers problem. Another approach has been to focus on mental health services, because that has lots of tie-ins and ACEs, social determinants of health, that sort of thing. That's been another approach. I would propose another approach, which is something that actually everyone has mentioned in their own way, which is that social determinants of health, that there are measures that I think are possible. They would be new, so there's that, but related to social determinants of health and equity. And we already have a game plan, we already have a map for the state, I think, that takes into account equity priorities and social determinants of health, prioritize the highest risk and disease burdens of the state in consultation with many stakeholders, and then prioritize the interventions that are most likely to work, and that is the SHIP, the SHIP that you're all familiar with. And so it seems to me like there's some kind of attachment here, potential, to get past not ignoring the idea of clinical, like health care equity measures, because that is important. But in addition to that, in the long-term, near future kind of thing, to think about what does it mean to push payers and CCOs and PEB, NOEB outside of the boundaries of the clinics and start thinking about the community's health as a system, because the healthcare system is a part of the community. It has a role, not the role, but a role in helping address the strategies that are tied to in the SHIP, as far as evidence-based best practices to address the highest killers in Oregon. And if those things succeed, in other words, if we innovate in such a way that we sort of nudge, we push these health plans, these clinics, the health systems to think about themselves as a community plug-in, as part of the community, and that their intervention isn't necessarily 100% always confined to the walls of the clinic. We have to be careful about the way that's operationalized because we don't want to duplicate effort or get people out of their lane. But if we are able to do that, then the health care system has tremendous potential to benefit from those successes in the communities. If we reduce tobacco use, for example, that has tremendous inequalities, inequities, I mean, in our state. That, just addressing tobacco use is an equity measure in itself, just because of the way the industry has targeted minority communities. Nutrition's another one. That's the way that the populations or the communities are designed. Has a lot to do with the nutrition you end up consuming, et cetera. These are big issues that it seems to me that this board has addressed in certain ways, and this committee has a role to play in some of that measures. So there's kind of these different ways to approach equity, is my point. One is the clinical, subdivisions by race. Another is, rethinking the idea of a metric to sort of push the boundaries of clinical, approach. So this is an idea.
That was very well said. I just want to unpack that to be more specific. Thank you, Sean. We talk about social determinants of health. You're often concerned that this is a catch-all phrase, that all that difficult stuff that's hard to change. And what we really mean is we mean social factors, behavioral factors, structural factors, and economic factors. But Sean, you also talked about moving, just unpack it a little further, there's a second component is moving upstream in order to bend the cost curve. And so these are measures that precede actually developing the illness and incurring costs. Which brings up, I think the third point was implied in your statement, is that it requires a redefinition of what population we're looking at. Because in order to move upstream, sometimes we need to talk about the population at large rather than the population in care. I think these are three issues that it's important for the Health Policy Board to come to terms with, is unpacking social determinants of health. What does it mean to moving upstream? And in doing so, are we pushing towards, are we advocating for redefining the population of who the measures apply to?
See, can I just make a comment? I think this is a true statement. I mean, there's been incredible improvement here in performance metrics. I think if you looked at those performance metrics and hired, the best economist in the country and said, so identify how much cost was reduced because of the wonderful performance improvement in any of these, in all of these metrics, add it all up. How much the bending the cost curve does performance on these metrics explain? I think you'd pretty quickly say, well, I'll do that, and I'll need quite a bit of money to figure that out, but it's not going to hardly be a spec. It's a substantial accomplishment that there's been this kind of improvement. But that isn't the reason why the cost curve has been bent in the last 5 years. I'd be willing to bet $1 million on that.
Just as a reminder, cost curve is one of three elements of what we're really focused on. So cost curve is clearly a part of,
Right.
of what we're focused on, but we also care about the overall health of the population, and we also care about access and quality for the patients in particular. So as I'm listening to this conversation and appreciating both where you're at in the process and this particular presentation, one of the things we were hoping for was the ability to provide some guidance where in relation to where you are right now. And so there were two things that came up for me that I want to check with the policy board members and see if we have some agreement about this. One is that I think it's clear that you all are prioritizing the things that you've been asked by the legislature to prioritize, and so that's great. And I think this conversation about health equity is a really important one. I think that distinction that we've been talking about, if it seemed as if this body was talking about a specific measure, metric, or set of metrics that would somehow measure health equity, I don't think that was what I've heard the body talking about. And I do think it's more specifically about how do we push those existing transactional, potentially transformational measures and the systems that are using them to be intentional about how they're considering health equity in relation to that. Over the course of the last year, the CCOs and the early learning hubs in the Portland metro region have specifically looked at developmental screening for 0 to 3-year-olds, which overall is we're both doing really well on as a state, doing really well on in the metro area. And when they looked at those figures in a disaggregated way, it was really clear that there are specific populations by race who don't engage in that system in the same way. And it gave both the CCOs and the early learning hubs an opportunity to then say, how are we going to serve the Somali population differently? How are we going to serve the Karen population differently and ensure that they're also focused on those issues? I think what we want to be able to do, and incentivizing that, I think, is a conversation between the health authority and the CCOs. Incentivizing that in PEB and OHB happens in those different spaces. That's not the responsibility of this committee, clearly. But as you do your work, I think that what we want to see happen, and so I'm checking for acknowledgement, is that you won't feel bounded by the legislative parameters, and that you will look to provide guidance and a framework that supports our existing systems to move beyond just transactional use of those metrics, but really being intentional about how they're affecting different populations. I don't know what that looks like, but I would hope that that is a part of the conversation and that you all are thinking about how you're able to expand your work in relation to that. The second thing that came up for me in this conversation is it's too easy to feel, for everybody, probably you all as well, to feel like the notion of long-term approach or goals then become things we just do down the road. I think you said kick the can. So as you're getting closer to that, it feels like getting more specific about what the timeline looks like for really grappling with some of those larger questions as they come to social determinants, health equity, become really important, and then thinking about how we as a policy board can support that, so that it doesn't just look like, well, these are too big of issues and they're out there, which I don't think is the intent, but it's really easy for that to be potentially the message and not the one that was that. So I want to check, are those, am I clear enough?
We're encouraging the committee to be creative and innovative.
And courageous.
And courageous, and not too narrowly defining the legislative directive.
Great. Does that feel
At least
right?
not letting
It
that get in the
resonates
way.
with me. I appreciate the summary. I'd also encourage you to consider and ask for additional support when you need it. You know, I'm imagining the kinds of conversations you have in your committee and the intensity of both what you have to cover today and what you're imagining in the long term to cover. And so instead of an either or a linear timeline, like how does this board support you and OHA support you in doing those things simultaneously so that you can, you know, kind of take a broader sort of front approach.
Great. And this has been helpful. What I'm hearing is this idea around equity is when it comes to equity in health care, pull that into the foreground. That does fall within this purview. There's some things to be sorted through. But the goal there would be, how do we incentivize health care to create equity in what they provide? There's this longer range one, which I think we're also very attentive to, and it's probably a yin-yang in healthcare, which is to some degree, some of us in healthcare have wanted to feel responsible for all of the differential outcomes in health that we see in the world around us. And that's overburdening healthcare with a bunch of things that aren't sort of in its lane: healthcare, economy, jobs, you know, built environment, those sorts of things. And again, just figuring out what role can we have. And I think as you clarify, what does equity look like in Oregon? What do you want it to look like? What do you want to address? Our committee's happy to be available to help decide how are we going to measure what's going on, how are we measure whether or not we're making progress. We can absolutely pull the healthcare piece into the foreground.
Great.
Well, I mean, all I would say is I think we'd all agree, these folks are the messenger.
Right.
So, you know, they're going to put
Yeah.
this message together. But if we really feel as strongly as we do, Zeke, we should get the CCOs in here and tell them when it comes to negotiating, we want you to be courageous. The insurers who do the exchanges. I can only imagine, having been in that world, how some of the insurers might feel about, so you want us to negotiate contracts that include this, and we're going to give up some of our chips for this? You know, they're just the messenger. The folks who end up negotiating this, that's where the tip of the sword is.
I mean, the only thing I would add is, I mean, these guys have a ton of work to just get this off the ground, but this is clearly going to be, I mean, this is a tool that the policy board has in its tool belt that it did not have before this, right?
Yeah.
Which is to really bring metrics together and to align it across various strategic plans, whether it's the public health advisory board's work, whether it's you know, the health equity committee, but you know, it's gonna be iterative, and I think there's some tension here, which I think is a healthy tension in terms of thinking about how do we focus, and how do we focus on the right things, and how do we, you know, on one hand set metrics, on the other hand, you know, you all can give us direction in terms of you know, the bar we want to set with CCOs or within PED or OEBs.
Any other thoughts? Thank you for the work you all are doing. I've had the opportunity to listen in a bit, and it's this was just a small reflection of the discussions you all are having in that committee. Also, just wanted to say I appreciate the minimization of, not all the way there, but of PowerPoint and the use of props. So you're always welcome. Anybody's always welcome to bring props to their presentations. I think that will be appreciated. And please bring back the our appreciation to the rest of the committee as well. You're doing really significant work, and I think what we want to make sure, to the point that you've heard from a number of members, is we really want to be able to support you all to do the work that we know you want to do, and to be as courageous and as visionary in that process as you can. So don't hesitate to let us know where you're running into barriers on that front, and let us grapple with whether or not we're in a position to help reduce those barriers. So big work. We appreciate it.
Well done.
Thank you. Yeah.
Yeah, just one concern that's not under their purview, but is a measurement concern. My impression is the only place that measurements related to healthcare-acquired infections is at the hospital performance reporting, which I believe is done, because it's not been funded. Its legislative mandate has ended. Those measures are lives. And clearly the history there is, if you put money and you put reputation, the hospitals get that done. And if you don't, they don't. That translates into real lives being saved. And it worries me that there would be some emphasis that would go away if that measurement activity isn't accountable somewhere in a very significant way.
I think
They
they're
are.
still in PEB, right, Sean?
I believe it is, yeah.
And that group will be reporting to us at our next meeting. And it is, we do have a hospital category in the set that we're working on. Again, that's, 1.5 million Oregonians, not the whole state, but we're aware of that change.
It does
But
remain in the
that
Medicare
ends.
measures, doesn't it?
I'm sorry.
It remains in the Medicare system as well,
Yes.
I believe.
Right.
Thank you all for your presentation. We keep moving our public testimony process up, and that is next on our agenda. If there's anybody who didn't get a chance to sign up for public testimony but was interested, let the staff know. I have one person, that's Kevin Fitz. I'm going to invite you up. Kevin is representing Oregon Mental Health Consortium, or Consumers Association, I should say. Welcome again, Kevin. You know the rules, 3 minutes, and we're excited to hear from you. What do you got?
Good. Thank you. Welcome, Chair Smith and council members. My name is Kevin Fitz. I'm with the Oregon Mental Health Consumers Association. I wanted to reiterate for the record two things that have caught our attention. Just let me tell you, our mission is to promote the voice of the consumer or the service recipient in public policy discussions. And so to that end, we're always trying to follow policy. Where have they heard from the customer? Where have they heard from the service recipient, et cetera, et cetera. And so to that end, Director Saxon is now gone, and we had been following some of the stuff that Governor Brown had said about why she got into public service and some of her values. And I just want to make a brief quote. She gave a commencement speech in 2016 to Willamette University. And this was Governor Brown said in spring of 2016, "I sought a career in public service with a singular mission, to give a voice to the voiceless." And I thought that was particularly interesting. And then following up with that, the State of Reform published a letter about Director Patrick Allen taking over. And she said, "Your highest priority," and this is from Governor Brown, "your highest priority from day one should be restoring trust with the public, legislators, stakeholders, and most importantly, the clients the Oregon Health Authority serves." So just a reminder, we are always interested in when people are talking about reports and policy, about when they use the term stakeholders, what do they mean about that? And I don't know if you remember some of my previous testimony in front of this Health Policy Board. An individual living with a behavioral health disorder can have a lived experience of mental illness or addictions. But an individual who is a service recipient receiving Medicare or Medicaid services, and Ben Carson is his landlord and Family Care is their Medicaid provider, is a whole different world of poverty, food stamps, public housing than a person who is making six figures and lives with a mental illness. And so we are, not that individuals who have the experience of mental illness at different levels of socioeconomic strata shouldn't be involved in the discussion. But it is very essential to us that the voice of the person who is receiving services or has received services as a public service recipient, that their voice is supported in the discussion. I have a lot of other feelings about many other things, but I only have 3 minutes. I wasn't able to make the last discussion, but I was paying attention to the discussion about pharmaceuticals, and I like some of the buzzwords that we hear about social determinants of health and upstream and saving costs and that sort of thing. There's the ongoing discussion about pharmaceutical costs is very interesting. But also, from the client and recipient point of view, the idea about pharmaceutical costs and the use of pharmaceuticals is something that folks would like to have a decision about. Ideally, if you went in and were seeking services, that you might want to like a choice of what would be the best treatment for you given that choice. And oftentimes, and maybe it's just through complacency or just hastiness, there's only one offering on the table, and that is you get a biochemical adjustment to your mood or your thought disorder, and then you're shipped on out the door. We are totally believers in that you spend an awful lot of money in your psychiatric crisis system at the front end, but what are you doing to build natural supports in the community? What is the long-term goal for people who are receiving public mental health services to get out of high utilization of services? And peer supports and building a community is a tremendous solution to some of those problems. So, anyways, thanks. Is my 3 minutes up, Zeke?
It is. Thanks, Mr. Fitz.
Thanks.
And nice transition for our next presentation. But before we get there, we're going to take a quick break. We'll run a little bit behind, but I'll get us back on schedule, I promise. Let's come back together at 10:25. Which is, according to my clock, in about 8 minutes. So I'll call you back in about 8 minutes.
Nice to see you. Good luck.
Great. So I think Director Allen has some late breaking news he's going to share with us. Late breaking in the sense that he just found it out, not in the sense that it was tweeted necessarily. Although it probably was, but that's not how you got your information, right?
Yeah, that's correct. Two things. The most important is that we now have a request underway for supplemental funding for CHIP from CMS, and we anticipate, according to CMS, receiving those funds by later this month, within a couple of weeks, I think is what I read, and so that process is underway, and we do have something working as it ordinarily does in Washington right now, so that's great. The second piece of news is that the House released its version of the CHIP bill last night, and it is substantially similar to the Senate version, and that's good news from a legislative process standpoint, because that means they're not in radically different places with a lot to work out. So I think that bodes well for this, in fact, getting resolved reasonably timely and without a lot of excess drama. The minute I say that, things may change, but that's what I had a couple of emails this morning about that.
So we anticipate being merrily on our way in that regard.
Merrily on our way, yes.
Great. I think, Jeremy, that probably doesn't negate the interest from the board in thinking about where we might send a letter to the delegation about some of those other issues.
We'll put it together, and then we can see where things
Great.
stand before we.
Okay, thank you.
Thank you. Okay, so our next item is an update on the status of the Behavioral Health Collaborative. And I think to introduce our presenters, Brenda, who acts as a consult to this work and is in that process defining what it means to be a consult,
Yes, right.
is going to introduce our friends. So
Yeah, it's my pleasure to introduce Royce Wolin and Dr. Mark Bradshaw, who are here to present on the Behavioral Health Collaborative. And just by way of introductions, these people work really hard, along with Jackie and other support from OHA, to try to really move this agenda forward. So I'll let you take it from here.
Thank you very much. So I get to do two things, so I might get a little distracted. My brain only works usually oftentimes in a very one way, so I might get a little behind on some of these slides. So I'm here to talk about the behavioral health, provide you just a quick overview again of what the Behavioral Health Collaborative was and is currently. Talk about the accountability structure for moving this work forward, the deliverables of the various work groups, and provide updates, and give you an update on our timeline, where we are, and then answer and then talk about the communication plan and then any questions. Our request for the board is for ongoing support. We're doing a lot of work with Health Information Technology Oversight Committee, the Healthcare Workforce Committee, and the Health Plan Quality Metrics Committee. So we would ask for your support in continuing working with those various entities. We also would like an opportunity to come back as we move forward in the Behavioral Health Collaborative and to provide updates on where we are. So these are this is a honeycomb style presentation. It's a little hard to read, but I'm going to pull out some highlighted statistics that are specific to Oregon that I think are really important, because we do a lot of really great work and we have a lot of challenges here. So suicide is the second leading cause of death for young adults in Oregon. Only 46% of adults receiving mental health help actually says that it helps. And 11% of Oregonians dependent on illicit drugs actually receive treatment. So we have some challenges ahead of us. So these were the priorities of the Behavioral Health Collaborative that were focused on improving the health outcomes of those individuals that we serve, the consumers, to ensure equitable access and effective service delivery across the state, improve efficiency and cost effectiveness of services. This no wrong door approach, what we realize is that most people don't walk into a behavioral health center to seek treatment. They oftentimes come in contact with the police. They might end up in an emergency department, EMTs. It might be a kid at school. So we recognize that there are various ways for people to identify mental health and addictions issues, and that, again, not depending on people walking, for us to depend on people walking into clinics is not a great way to focus some of our efforts. That mental health and substance use disorders are seamlessly tied. The focus on prevention and health promotion, really getting ahead of this, ahead of the curve, and then system-wide accountability.
Royce, can I just ask you a clarifying question? So, the Behavioral Health Collaborative was initiated by the health authority somewhere in the last 16 months. I can't remember exactly when. So it's really a collaborative that's being organized by the health authority under your department at this point, and then has a large group of stakeholders, individuals that have been engaged, right?
Yeah, so we started, the collaborative started, and I can go ahead. When I was looking at this, I was thinking this slide should have gone first. Where is it? Oh, there we go. So the collaborative started initially from a listening tour that happened with Lynn Saxon and Senator Gelser. And then, honestly, through feedback that OHA had received around behavioral health services and provision of services across the state. So OHA pulled together about 50 stakeholders that included providers, county mental health programs, CCOs, education, criminal justice. We had a judge, we had a sheriff, so whole consumers. We had a whole slew of individuals that met for about 7 months, and they finished their work on January 31st with these 4 high-level recommendations around governance, finance, standards of care and competencies, workforce, and technology and outcome data.
So, sorry, when you said finish their work, does that mean that the Behavioral Health Collaborative is completed, or are you part of the presentation going to tell us what moves forward, and is it the same set of, like, I'm trying to get some sense of what we mean by collaborative, because it seemed a little fluid.
Yeah, so the collaborative has gone through several different phases. So the first phase was having all these individuals meet. The second phase was really looking at the document, the recommendations that were approved by these 50 some odd individuals, and then breaking those down into their essential components, which there are about 120, 140 of those. We then took those and we grouped them into different focus areas. So one was governance and finance, workforce, peer-delivered services, standards of care and competencies, data, and then we have a group working with DCBS around parity. So those groups have been meeting for about 3 months. About 90% of their work is complete at this point. A couple of the work groups are still continuing their work. So, for example, the Governance and Finance Committee would like more time to talk about the risk/benefit sharing model that was brought up during the Behavioral Health Collaborative. So we got most of the recommendations done by the end of August, and we're feeding those recommendations to the steering committee for additional review and consideration. We also need to look at what resources need to go towards those efforts and those recommendations, and also which recommendations will make the biggest change and the biggest impact. And so they've completed, again, about 90% of their work, and now we're just reviewing their work, adding some more context to it to inform the steering committee, and then we'll be looking at those and prioritizing what those are.
And same 50 individuals still engaged through those work groups, or is it have additional folks and/or?
It's actually additional folks. Okay. So with the governance and finance work group, all of those members, with the addition of a few more, and then subject matter experts from OHA, are in that group. So most of those are from the collaborative. And then in order to use existing advisory committees like AMPAC, OCAC, all of those, we embedded the work or the recommendations within those bodies to further work on the deliverables and further kind of tease out the recommendations. With more of the health information piece, we moved over to High Talk. The data piece, which we're moving into, which really has to do with metrics and coming up with a menu of behavioral health metrics to present and move along and get decided upon.
Great. And then you mentioned steering committee. So is that there's a smaller group that is in effect guiding the work moving forward?
Yeah. So there's a steering committee. It's Pat in his role. It's Leslie Clement. It's myself. It's leadership from DHS. It's health analytics leadership. So it's mostly OHA and DHS leadership that meet and really kind of vet the work, ask questions, and we'll ultimately decide on the priorities of what we move forward.
Thank you.
So we're just, correct me if I misstate this, but it sounds like the collaborative really came up with sort of the higher level vision. These work groups are now sort of in the more the implementation details phase.
Yes, exactly. Yep. All right. So again, towards the effort of tying this work into other initiatives, projects, plans, we are tying this, and you can see on this illustration where the Behavioral Health Collaborative work specifically fits within the Action Plan for Health for 2017. We're also ensuring that the Oregon Performance Plan is rolled into or aligned with these recommendations and this work. And then we're looking at our federal block grants again to align with this work. So these are the 4 high-level recommendations, again, around governance and finance, really a focus on a regional governance model for behavioral health, standards of care and competencies, a real focus on workforce, because we know that we have a shortage of workforce, information exchange, and care coordination. So these are the 4 high-level recommendations that the original Behavioral Health Collaborative voted on. So we did not have, for recommendations 2, 3, and 4, there was almost complete consensus. Recommendation 1, I would say we probably had about 90-95% consensus because we got to a point where we needed people to vote on those.
Can I ask a question about these? There was the mapping project that we saw a couple of years ago that was around access to care. But that's not one of the recommendations or the strategies, I think. So what happened to that?
Yeah, so it's up and running. The work has been completed. There are a series of 5 or 6 different maps, and so I'm happy to get you that site. And so what we've done is we've mapped out where providers are across the state of Oregon by provider type. We've also looked at distance to access providers, so I believe it's a 50-mile radius of kind of where the population is and where there are providers. We also have provided information around poverty, prevalence of addictions and mental health, those types of things by the state, and then you can break it down by the county. So that's up and running. We are moving that function over to Health Policy Analytics to manage that tool so that we're able to add additional features to it. So for example, maybe adding APD offices or child welfare offices in order to really fully utilize that tool.
I guess my question is, are any recommendations, sort of you started with the any open door policy, then we created that map, and then did the group have a discussion or any recommendations coming out of that access outside of just the workforce, or maybe we can talk about that when we get to workforce? Sorry.
Yeah. So we are entering into we do have a contract to do a workforce assessment, identify where workforce is, where there's need, and where there are gaps, and developing then strategies to address those.
I have a question as well, Royce.
Yeah.
It seems to me, if I recall, when this formed, it was a conversation between Chief Justice Balmer and Lynn Saxton about having this conversation around behavioral health. And so my hopes were that there'd be a lot of integration in the conversation around systems that included criminal justice.
Mm-hmm.
And I understand that there were a number of stakeholders that represented that field, that participated in the collaborative. So I wonder if you can speak a little bit to how does some of that work, or those concerns or issues of creating more alignment as to the current system, which is really quite separate or siloed. How does some of that fit into one of these 4 recommendations?
Exactly. So I would say it fits really well with the single point of shared accountability, and I'll have Mark jump in as well if you have any added comments. And that's really, again, bringing those individuals together to focus on priorities that are locally specific, which includes that breaking down of silos, sharing of resources, and really focusing on what the individual needs in the moment.
So when you say those individuals, who are you referring to?
So I guess it kind of gets into the governance and finance group, and I'm Mark Bradshaw. I'm a member of that group and have been from the Behavioral Health Collaborative from the beginning. I'm a psychiatrist and I've practiced in Oregon since 2003, and I'm Chief Medical Officer of All Care, CCO, so I wanted to at least disclose all that. The best way to look at what the governance boards is exactly what you're talking about, is trying to find a way of bringing all these organizations together who have common interest around mental health to try to align the funding and develop goals locally that they all work toward, as opposed to either kind of in conflict or duplicating. So that was the idea of the governance and finance regional groups. So to tell you about that, this has been going on for some time about what these groups will be. It kind of comes up with trying to find a way to break down silos, to do it regionally, but at the same time have a process that's predictable throughout the state for measuring outcomes and moving the state toward the goals that it needs to be meeting. The groups that will be calling together, and this is getting to your the groups that will be calling together these entities, regional entities, will be those that have contracts with OHA. So OHA has obviously some control over those people who contract with them, and that would be CCOs, the local mental health authorities, public health, community mental health centers. Those will be contractually obligated to put together these regional organizations, and those will be, by definition, including criminal justice, education, hospital systems. Peers will be mandated to be on the group. So that hopefully maybe answer your question.
That would be part of the deliverable from the governance piece of this work group?
Yes.
Okay, thank you.
Yeah, and we're finding that calling it a single point of shared accountability really brings up some fear and concern. So we are looking at changing that name because what we're not doing is we're not moving money around. We're not changing money. What we're asking for are these entities that do have resources and are working towards similar goals to align those goals to help, for people not to enter the jail system or not even have an interaction with the police, and trying to figure out those systemic issues, because as you mentioned, there are silos. I think in some areas the silos are less, in some areas they're greater.
One thing that might be helpful on this front, previous report from you all, one of the recommendations was that you would be, to the extent possible, aligning and building on the Oregon's Performance Plan for Mental Health Services for Adults with Serious and Persistent Mental Illness, which came out of the collaboration with the U.S. Department of Justice Civil Rights Division. It might be helpful to see a crosswalk between those particular recommendations and the recommendations that are coming through here to get a clear sense of where the systems actually are connected. So, and
Yeah.
then the other thought I had, that it may come up in the conversation, one of the other work groups that you initially had was the Waste and Efficiencies Work Group,
Mhm.
and I know that that was incorporated into the other work groups,
Yeah.
but it'd be helpful to see where that work shows up
Okay.
also, to get clarity around this kind of issue that people
Yeah.
raise around creating efficiency around administrative
Yeah.
burden.
So I was on the waste efficiency work group as a provider, and so I have a passion for the work that we did, because the recommendations were very specific, and I think those recommendations are really will help us to move things forward. So we can do that.
Also, I was going to talk about the DOJ, that work plan that the state has, that obviously plays into a big role in this, and it kind of gets into these regional governance and finance groups. We're trying to kind of figure out a way of not being prescriptive and saying you have to do this, at the same time giving regions kind of a voice as far as how they want to manage the issues they see as problems. But we also have the state mandate that we have to meet by the DOJ. So right now, the governance finance group is really kind of working on how do you do a balance. Do we do like you have 3 goals each region has to come up with, but one of those goals has to be from a state list. How do we make sure that those are being addressed? At the same time, realizing that the DOJ work group is not really sufficient at moving our mental health system forward, because it doesn't mention anything about children. I mean, and that's a major issue. So we can't just use that as a format for how we're going to make change in the system. So hopefully that's kind of answering it. It's definitely there, and we're definitely looking at it, but how do we do that without either mandating that each region does a certain thing, also without ignoring other big deficits that we know that are contributing to the mental health issues and behavioral health problems in the state. So.
All right, and then we wanted to bring up some of the kind of points of consideration, points of kind of lots of conversation, and so we had a lot of conversation about being overly prescriptive versus being flexible. And so what we came up with is that OHA would be very specific on the accountability piece, including who's at the table, and then what the priorities are, the plan for the priority, and then monitoring those outcomes, but not to be prescriptive of the process, because I think when you look across the state, things are done differently in each county, each area, and each CCO region. We also talked a lot about who should be on the single point of shared accountability, and who has authority-making decision. And so again, we came up with some advice and suggestions, but again, we're not being prescriptive in what that will look like.
There would be some membership, though, that would be required.
Yeah.
And then other left open to what the community feels that it needs. So.
Is this one of the places where there was some disagreement about whether or not this is the right approach to addressing the problem? So, or was there a universal sense that single point of shared accountability, however it gets implemented, was the right solution to the problem?
I would say there wasn't complete agreement that that's going to resolve the issue. I think that that's the minority opinion. I definitely
I think
can weigh in on.
this came early on in the Behavioral Collaborative when we were meeting in a huge group, and the major issue that you go through this group and you figure out what are the big problems, and everybody calculates their big problems and they come together. But the common thing was the fact that it's a very disjointed system with lots of silos, and so how do you fix that? And how do you do it in a regionally and local way? And so that's where this idea of a single point of accountability came up. And initially it was the CCOs that the group said, or it was, I won't say initially, but it was one of the proposals the CCOs would take that. And both the CCOs and non-CCO members were not necessarily crazy about that, because there's lots of aspects of mental health that are really outside of what the CCO's preview is. On top of that, you don't really want to pay your as the mental health authority. I mean, there's a definite conflict of interest in that. So the idea of these entities came out of that. How do you make an entity that would be accountable, but that you included the organizations involved in mental health? So that's where this came from, and it was early on. So I agree. I think that actually there was more consensus around that, having groups. The disagreements come as far as how does this going to happen? So what do they do and that sort of thing.
So another question, trying to understand this single point of shared accountability. That acronym, is that SPOSA?
SPOSA.
SPOSA? The SPOSA. And you refer to it as an entity. Are we actually creating a new entity? And is that going, I mean, we're working with a platform that's already very resource scarce.
Yeah.
And especially in rural Oregon, many of the people that serve on these different boards of these regional representatives that you're referring to are often one or two or three individuals that have multiple hats. So I'm trying to scale this concept to rural practitioners and systems, and I'm wondering if is the expectation that the SPOSA will actually be a newly formed independent entity and will have new duties, and will that be a funded entity from the state?
Well, I think that it depends on the region. So there's already regions that have groups like this. It may be already happening in, for example, in Jackson County, they already have a group that kind of meets to do a safety policy group. Central Oregon has a group. So some may be adapting existing groups to this. That's part of the mandate. We're not going to mandate that you have to do a new group. If you already have a group that these people are there, you may modify that group to try to meet these requirements. One of the big issues is funding. I mean, that came up. This is going to be additional work for organizations, and that is one of the things that we discuss, is how that's going to happen and be funded. And honestly, this is kind of from my opinion. I think that funding is going to be an issue. You know, we can and have to figure out a better way of getting rid of waste, trying to get rid of duplication, make this system more accessible. And I think that that's going to work, and that's going to help if we can do that. But to be honest, if we don't fund the system appropriately, you know, it's not going to change. And when you are not paying your providers, and I'm not talking about psychiatrists, I'm talking about peers and peer providers and therapists enough that they're going to Starbucks to get a job, you're not going to have a good system. So we can dress this up all we want, and we can make the modifications we want, but we have to be honest that at some point, once that's done, or during that process, we have to be honest as a state. We have to provide appropriate funding for this, or it's not going to get better. So that's my side.
We're also looking at administrative burden and reduction, looking at where we request data that we may not need, data where it's collected in other areas. So we have spent a lot of time, and we've agreed to spend energy and time in looking at trying to reduce some of that administrative burden, because we aren't putting more money into this. And we recognize this is an additional ask of communities to do this. So that's been kind of our answer, is that we've promised to start, and we have started looking at all those data reporting requirements. We're also looking at aligning our block grants, or both substance use block grant or mental health block grant, with this reporting requirement of the SPOSA. So we feel very strongly and passionately about looking at those and where we can to really reduce that in order to free up time to work on this.
I very much like what you just said. I would encourage the conversations and the language to be around supporting local community systems and not regulating. When you look that language of accountability, frankly, I'm not sure who's going to sign up for that job.
it's having participated
Yeah.
a little bit more in some of these conversations, I think it's important to recognize it's on a continuum. Some communities are really actively involved in this space and are on their own volition making really significant headway. And others get stuck in the silos and in the structures that are built that keep them separate and apart. And so I think when I listen to these folks talk about the spirited debate around this issue, I think it's been, what's OHA's role from its contractual authority position to insert specific space to require more coordination and collaboration across these disjointed systems, and not so much, as you said in your introduction, to take away the local kind of flavor and the feeling or diminish somehow that initiative or momentum that's already in play. So where that sweet spot is on the continuum, I think is the challenge in front of this group for sure.
And the governance and finance group has been remarkable around that. So you have CCO, CMHPs, providers, and you have some really bright people. And so we recently, or actually over the last month, we've talked about how do we communicate that, because those individuals know a lot of information because they've been working on it for a long time. But how do we do it and do it in a way that it's not OHA coming to the communities, it's us partnering with the CMHPs, the CCOs, local public health, of figuring out how to pull together that kind of meeting to really talk about what it looks like and not, really force it, but really be supportive. So part of our conversation would be is what kind of technical assistance would you like from us? How can we help you to move this forward? They're a great group, and they really challenge us around looking at our own systems and how can we do better. Anything else on that work group?
Yeah, can I just ask, it seems when you're trying to do something voluntary, the only hope of success is to actively identify the folks who are volunteering and doing a good job.
Mm-hmm.
And as a result, identify the folks who aren't.
Yep.
Is that going on?
So that's what we're hoping to. So we already have a sense of who's ready to go. We have a pretty good idea. I've been reached out to by a couple of CCOs saying, have you completed your document that describes this? We're really interested. We're ready to go. So I think that we have a pretty good sense, but we don't have a complete sense. And I think part of us going out to the communities and arranging these conversations and bringing our partners, so bringing the CCOs who participate in the governance and finance work group, or the CMHP, or the providers, to come along with us, because it's going to be a different message from Mark than it would be from somebody like me. So we really have spent a lot of time on thinking of how we're going to communicate and engage in a way that it's not OHA coming in and forcing it.
And patients are part of this, and
Mhm.
this
Right.
is a public process that's going on, and
Yes.
so if you identified a good voluntary performer, there would be patients in that community who would say, yes, we've noticed a difference.
Right. And exactly, part of what will need to happen is when these organizations put their goals together, they need to be able to show how that's going to impact the people in the community and how you're going to measure that. And one of the hopes when you have a group of voluntary organizations getting together is that if you set it up regionally where they develop their own goals, they have an interest in that happening. If they're all seeing a certain problem, then they're more likely to be really committed to making that happen. And this was kind of modeled after Central Oregon and something that happened there where they started a group like this because of a problem, and then they've continued that work. So.
Yeah, and the Gorge, I believe, has some model that's is similar. And so they've done some of this work, and they've been providing us with technical assistance around what that looks like and what they've done.
I do think as you continue to work on the governance and finance work group, we get stuck in this space where we either say, well, we don't want to mandate something, we want to let everything kind of happen at a local level, and or we know that we've got a statewide problem, and so we're going to mandate it, and yet we lose transparency sometimes in the conversation. So I just think as you think about this, for the health authority to be really explicit about what levers for change it does have at its purview, and how you're using those and how you're going to use those differently, even where that's about a mandate, even where that's about expectations, even where that's about contracting, for local entities to be able to elevate where there are really good things happening and how that might inform what's happening in other places, and then for us to think as a system how we want to see that kind of consistency happening. Sometimes it gets lost in the mix and it's hard to see. So who's actually driving what trains, and what are we actually, I mean, it's too easy then, I think, for us to raise all the issues and concerns with the potential solutions in a way that means that we don't actually make any progress on the problem. So I just would encourage you, as you're working through this, don't be afraid to be really explicit about what your role is as the health authority, and to be clear about that, but also what those limitations are in order to do that in a way that's effectively integrating local realities. And don't shy away from that conversation. I'm hoping that you don't, and I think as you make visible the solution points, getting really clear about who has what authority over what will be really valuable.
I think I'm glad you brought that up, because in our last session, we were encouraging the metrics committee to be innovative and come up with new ideas, and here's clearly an area which is ripe for innovation. I think messaging, what could be done in terms of metrics and outcomes and contract negotiations is really important.
Yeah, so our levers for making this happen are contractual changes with the CCOs, the CMHPs, local public health. There's also some Oregon administrative rule changes that we can make that specifically talk about the relationship between a CCO and CMHP. So I think that we have some of those levers in place to move it forward. And yes, we'll be clear on that. And I want to start from a place of kind of engagement. This is a great thing. This is a great opportunity to pool resources and to really focus on those behavioral health needs of that specific community.
I feel like this reminds me a lot of when we first started the discussion about CCOs and how we walk this line of tension between, being very prescriptive and non-prescriptive. And you remember there was a lot of conversations about that, and that building trusts in a community that were oftentimes competing and saw themselves as competitors for a pot of money or a patient population. And so I think that I just have I would say I have a lot of hope about this. And then I think when you talked about who's at the table and the priorities that were set earlier in the presentation, I think one of the lessons about the success of the CCOs was that strict requirement of who was at the table, and also the strictness about the CATs, the engagement of the patients in the process, because I think that and what their role was. And so you don't have to do it now, but at some point can we get who's at the table? Because I do think that helped a ton in CCOs getting the right table set.
So it's not in there, but I have the list of what is on there. The mandated group would be those with lived experience. So the patients, families, caregivers, and tribes would be the mandated group. The others that we've not mandated yet, but on the list were education, criminal justice, public safety, child welfare, early intervention, hospitals, health system, developmental disability systems, aging and people with disabilities, veterans, behavioral health providers, primary care, and advocates. All these should be inclusive of cultural, linguistic, and social diverse populations. So
that's a big
Yeah.
group. I mean, I think it's really, that's great.
We're not, I mean, so the contractual required individuals, again, are the CCO, CMHPs, local public health, and
Okay.
then you must ask tribes to participate, and
Okay.
they can decide whether or not they
And
want to
peers,
participate in
the two.
peers. Yeah.
And peers, okay.
Outside of that, it's really guidelines that this is who we recommend
Got
that you
it.
have at
Okay.
the table.
Right.
However, we are going to be looking at the letter of intent, which will include the convener, who's going to be kind of the reporting mechanism, and then a list of who they have, and that will be our opportunity to say, you only have 2 consumers, but you have 25 people. That's not enough consumers. And so that will be our opportunity to provide feedback.
And so the consumer group is integrated with the rest of the group in this case, not unlike the CCOs.
That's when they would be integrated, right?
That would be our hope. I mean, I think that's part of the risk, right?
That's great.
That would be our hope. And still, we still have a process, and if that's what OHA decides is an important route to go to specifically require certain individuals, then we can consider that. I think the consumers are key out of all of the individuals or groups listed that aren't mandated.
And so on the mandated groups too, I know the tribes is one of the groups that is mandated, but it's a request to the tribes. And then Veterans Affairs is one of the groups that is, I heard veterans on there sort of as a consumer group, but the Department of Veterans Affairs in some of these cases, are we a request to them, similar to how we request of the tribes?
Right. Well, that group, I believe, would be depending on the region. And so if the region really felt that was a major issue, they would be bringing them in. So veteran.
Okay.
I wanted to acknowledge,
Thanks.
I think we've derailed you all somewhat from
Oh,
the presentation. We appreciate that we got the materials ahead of time, so don't feel like you have to hit every point, and I'm sure we'll ask questions where we have them, but just so you get a chance to keep moving through.
Yeah. So standards of care and competencies, establish core competency for behavioral health workforce. That's really important. Also, a minimum of standards of care within behavioral health centers. So what we heard through the Behavioral Health Collaborative is that if I go to a place in, let's say, I'm trying not to pick on anybody, Southern Oregon, and you go to a place in Bend, you don't necessarily get the same basic level of service. Care coordination, case manager, peers, doc, those kinds of things. And so we're looking at those, and we're researching what those standards are across the country. And we've also developed standards for the CCBHCs that we're using. So this is their update, that they have completed their work and have made recommendations around the competency for providers, minimum standards of care, and then care coordination, and to ensure that care coordination is paid for in order to assure that it happens, and there's mechanisms to make that happen.
So, Royce, for example, with the care coordination, establish minimum standards for care coordination, is the recommendation that has been where there's a consensus agreement that that we should establish minimum standards of care, or is there a specific recommendation about what those minimum standards of care coordination are?
There's specific standards of what those minimum standards of what should be provided at a clinic, and then also best practices around care coordination.
Great, thanks.
Can I ask a question about the minimum standards of care too?
Yeah.
Are we applying those in our correctional facilities? Is that part of this?
So that is a great a great discussion. So earlier I talked about kind of points of entry and how people access behavioral health services, which is not usually the traditional way, and those kinds of things. So we have a list of kind of points of entry. So again, EMTs, ERs, schools, criminal justice, all those kinds of things. And so we do have recommendations for a number of those areas, and those were guided by the Farley Center, who's done a lot of work around this. And so that's a huge task. So for example, school teachers get mental health first aid, but because of union rules or guidelines, they can only spend 6 hours in mental health first aid because that's as much time as they have. So we need to modify mental health first aid or do something different. So we are looking at those, and we're trying to think of which ones we can be the most impactful with, because it's really going to be us providing influence.
I want to make a pitch for criminal justice.
But that was also a long way of saying, no, we don't have that authority, but we're going to try to influence it.
Yeah, yes, exactly, yeah. Because there's an interest, right? I mean, so it's figuring out where that interest is, where that momentum is within those different points of entry, and how do we tap into that?
I think that I'm interested in sort of moving forward on areas that the state is in charge of the healthcare for the population. About there's areas of interest when you're trying to bring communities together. I think that prison in and of itself and the correctional facilities have their own sort of community. I don't want to, not recognize that, but I do think that there's a very different sort of like that we've created a mandated community of people who we should have a bare minimum of standards for, sort of these core standards for.
Mhm.
And I feel like also the biggest bang for our buck and savings in the long run is, engaging in mental health and substance abuse treatment, behavioral health issues in our correctional facilities. So if it's a legislative barrier, if it's they don't have the will barrier, like, I feel like our hope as a board, we could figure that out.
I think the pathway into continuity of care is an interesting door in that particular space. So while there are these mechanisms that prevent and disrupt care coordination across those systems, when we think about the population as a whole that are in and out of correctional facilities,
Yeah.
they're in community.
Mhm.
So how do we think about extending the care model itself through other mechanisms?
Also, just for the collaborative, for the
Yeah.
group, as you think about that, it would be easy to focus on where OHA has direct authority,
Mhm.
and then to put in another bucket those other places that still may be under statewide purview, but where the
Yeah.
health authority doesn't have authority. The policy board has a clear interest and is a vehicle for moving some of that.
Yeah.
So just think about where some of those other areas are and how you might frame that as a set of recommendations for us to consider where we can take action.
Yeah, and we'll be, as we look at each of the recommendations, we'll be identifying exactly those kinds of things, of what are the levers and where do we not have administrative authority, and but that isn't going to stop us. We need to figure that out, and thank you for that help. The workforce work group, as you know, we can't do this work without the proper workforce. We hear over and over high turnover. I hear from peers or consumers that every 6 months, 8 months, 12 months, they have a new case manager. And we know in this field that the most important thing is the relationship that you have with the individuals that you're working with, the clinicians and the clients. So there's a strong interest in looking at workforce. And then again, standards for a well-trained workforce. And when I think of behavioral health workforce, there's a whole array of different types of providers, from psychiatrists to those individuals who provide habilitation and personal care services in a residential facility and have no credentials.
Just quickly, it says completed September, October 2017. Does that mean it is imminent, or have you actually, have you all been able to complete that?
So that one's in process. That's the 10% that's remaining that we're working on.
Great.
Yeah. We have entered into an agreement with the Farley Center through the University of Colorado. They've done workforce assessments for us before. We're aligning this work very closely with the healthcare workforce. So the idea behind this is that they will identify where we have behavioral health staff, where we have need, and then where are we missing those essential staff. And then we'll be working with them, since they've done this with various states, on recommendations on how to address those workforce needs. And then some ideas from the workforce work group, and we're working on this actually currently, is loan repayment programs, outreach efforts, and then we're also working on providing some training to providers around retention and recruitment of staff. The peer-delivered services work group, they've completed all of their work, which has been great. It's been, in that group, we probably have 40 to 50 people involved, providing feedback and input, predominantly peers, peer-run organizations, so a whole group of experts around peer-delivered services. So we asked them to develop standards and expectations around peer-delivered services workforce. We do have trainings that we approve at OHA, but we want to look at seeing if there's a way to increase those trainings. For example, around boundaries and ethics, I think is one. And then we spent a lot of time talking about what a peer-delivered services supervisor should look like, and what qualifications of that supervisor. And again, ongoing standards for training of peers, effective use of peers. We have a number of peers, and I think that they do well in some organizations, and some organizations they don't do as well. And it really comes down to the infrastructure of that organization and knowing what peers' role and responsibility is in training their staff and making their system modifications to make sure that it's supportive of a peer-delivered workforce. So again, this is just what they've delivered. The Health Information Technology Work Group, which sits with HITALK. What's been great about this work is that their plan for this coming year is really to focus on behavioral health and behavioral health providers. They recently completed a survey of, I think, over 100 providers, talking about what EHRs those providers are using. Do they have an EHR? Are they able to get data out of their EHR? Are they able to use health information technology to share information? So it really was to get a baseline of what's out there, what the needs are, and they will be publishing the results in December, and that will guide them around their work plan and strategies for improving technology within the behavioral health provider system. So I realize I only have a couple more minutes, so I'm going to skip through a couple of these. We're also in a partnership with the Department of Consumer and Business Services, where we are part of an academy talking about mental health parity. So my administrator, Mike Morris, participates with a colleague from the DCBS. We also DCBS received a $600,000 funding regarding behavioral health parity. And so, again, we're aligning those efforts and working closely with them to see how we can support those efforts around the private health insurance system. The data work
If I could
group-
just comment on that real quickly,
Yeah.
since I actually know something about
Please,
that.
thank you.
Part of it. The biggest piece of work is going to be a data call, which is a tool the department uses with insurers to find out what, answer questions about claims patterns or things like that. One of the things I remain concerned about is that I think there is a frequent and widespread misunderstanding of who is actually private insurance and who is not, especially in this space. A quarter of Oregonians think they're served by an insurance company and they're actually being served by the third-party administrator for a self-insured business. And we are utterly preempted by federal law from any regulatory activity in that space. And again, that's a quarter of Oregonians. So I just want to keep taking the opportunity to point that out, that just because it's, I won't pick the name of a particular company, but just because it's somebody you think of as an insurance company does not mean it's insurance. And in my experience working with the DCBS advocates, almost always when there's some difficult challenge, I shouldn't say almost always, very frequently, it's a TPA circumstance, not actual insurance. And so we may be aiming at not quite the right target in that body of work is what I'm concerned about.
I think just to add to that, I actually feel like we have a trust, a Taft-Hartley trust. We had this issue with mental health parity in our trust arrangement probably 4 or 5 years back. And I mean, we didn't even realize it because we had assumed, thought that maybe it was covered under state law. So it is not even it can be a misconception even if you are running a third-party administrator that you assume that you have mental health parity and you don't in your plans and you haven't designed your plan correctly. So.
Thank you. The data work group really is focused on developing a menu of options around behavioral health outcomes. So we'll be working with, I always get this, the Health Plan Quality Metrics Committee, and submitting a menu of options to select from. So that group is starting in about 2 weeks, and we're currently identifying members for that group, and we're planning to complete that work by the end of December. We already have a list of some metrics, I think actually a couple of hundred metrics to kind of start the conversation specifically related to behavioral health. We didn't come up with the 200 and something metrics, it's from HEDIS.
What would be a couple of examples of those metrics that would fit into this?
The new metrics?
Mm-hmm.
That's a really, really good question. I don't know if I can answer any off the top of your head. I mean, I think for me, it's really getting to, at the end of the day, did I benefit from meeting with you, seeing you, and somehow, got some sort of resource? We need to get to that level of metric in my head, because I need to know the person when they walk out the door got the service they needed. And because sometimes, you might come in and you're seeing your therapist, but honestly, you haven't eaten for 2 days. So that might not be your main concern right now. So for me, it's really looking at those kinds of person-centered outcomes, which is really hard to measure. It's not an easy lift.
Right. I find it really interesting to try to measure behavioral health outcomes because it's so different from some of the other, like
It
measuring
is.
your blood pressure or
Yeah.
your weight or something like that. So I'm curious what some of those measures will look like.
Yeah.
Traditionally, it's been screening for depression.
Mm-hmm.
It's been follow-up after an acute admission for mental health problems. How many of those folks are seen within 30 days?
Yeah, but to measure something more like what Royce was just saying.
Yeah.
Right.
Like I feel better
Kristen might have
after
a
my
comment.
visit today.
The best one I saw recently was actually employment rate for people with severe mental illness. That felt like a patient-centered outcome that really showed you're making a difference in people's lives.
And that's the hope for the data work group, is to come up and actually the governance and finance group will have a member on that, because we're really looking for how do you know that the system is moved, how do you know you're moving that way, and to try to come up with things like that as opposed to a 7-day follow-up.
Yeah.
So,
And kind of bringing back to what Kristen presented during her presentation around knowing what you want your outcome to be and crafting your measurement around how will you know if you get there or not, I think is even a bigger challenge in this area than in like primary care or dental
I would
or
agree.
hospitals or things like that.
Yeah, I mean, I think it's important to identify exactly that process, right? I mean, what do you want to measure, and then figure out how you want to measure it. I think that's a better way of approaching what
And I would
we're
assume
looking
that
at.
this honeycomb of all these less than stellar statistics for Oregon, there's inside each honeycomb, there's a list of reasons why. And I'm assuming that the Behavioral Health Collaborative chewed on those reasons why. And that will transfer into the creation of some of these metrics and the ability to measure whether you're making
Yeah.
a dent in some of those reasons why.
Exactly, yeah.
One process update. We're going to give this another 5 minutes, and then we're going to move to our last item. So just to be clear with everybody, and then just a point in terms of this slide. Just a reminder that the Health Plan Quality Metrics Committee, as we heard earlier, actually is providing metrics for the CCO system the health exchange, PEB and OHIB as well. So as we think about the relationship between your work and theirs,
Yeah.
don't limit it to the CCO system.
Yeah, thank you for that reminder. So we've done some of the work already and are working with the Transformation Center around a series of webinars, data sharing, blended funding models, ensuring equity, transparency within our governance model. And then we're talking about a one-day event focused on hiring, retaining, and using peer-delivered services. So I'm happy to say we're in phase 4 of this, and that most of the work has been done. Now we're in the process of reviewing the work, presenting the work to the steering committee, having understanding of what that work will mean for OHA, and then we'll be looking at prioritizing that. And again, we'll be doing our, for lack of a better term, our road show around communicating this work and talking with various communities. So phase 4, we're standing up our core team, and that team is really the subject matter experts within OHA and DHS that will give us a better understanding of what the lift around the work is, what it will require to do the work, and then we'll help move the work forward. We are in process of looking at CMHP contract changes. I was on a phone call about that earlier today. Depending on what the CCO process is, figure out a way to influence that. We're also, again, looking at organ administrative rule changes that specifically talk about the relationship between the CCO and CMHP.
So just one other,
Yeah.
encourage you to think about an additional bullet there, like we talked about, that has to do with kind of areas of influence, particularly as we think about other state responsibilities. Mark, I want to ask you a question. So, being deeply involved and having reviewed all those changes, if we're moderately successful in implementing on the changes that have been identified there, what looks different in your community as a provider and as a CCO leader? How do you feel like this addresses some of the honeycomb issues? And I'm allowing you to kind of wax aspirationally here, but I'm just interested in your perspective on what this effort really means in terms of transformational change that can occur on the ground.
Well, I'd like to see, I guess I could talk what I would like to see. I think one of the things to always remember when we think mental health, we also have to think addiction. I think that a kind of a change in how that's delivered so that we're addressing it faster. We're having prevention, which prevention is something that we don't really talk about a lot in mental health and behavioral health, but I would like to see that. I would really like to see more involvement in schools and with children and families. I think that there's a kind of more wrap type of services for families that are having issues of mental health and drug abuse. Because I think in order to really change the system, we really need to make sure that the children are not experiencing either mental health issues or results of their parents' mental health issues and A&D issues. We've got to be able to address that. So I think that would be the prevention and starting points would be changing. Obviously hospitalizations, psychiatric hospitalizations and sitting in the EDs for days, those would be definite areas I would want to see change. And more services being able to be provided in the community in an outpatient type of setting. And I think the third would be related to actually the measure that they were talking about, which would be looking at more of a recovery model, which I don't know that we really have in moving people into work, into shelter, into housing. And I think that hopefully that's a good summary.
And you feel like this array of recommendations moves us towards those aspirations?
I hope so. I believe that it provides a place for dialogue for these agencies, and specifically the state agencies. So I'm really glad you said what you did. I mean, having criminal justice at the table with the CCOs, the community mental health centers, having education there, that we start that kind of dialogue to deal with it and address that and have a transparent conversation about it. I don't think it's going to be easy, and I wish I had, some kind of way of forecasting what's going to happen, but I do know that we've got to start somewhere where we're able to talk about these things, as opposed to it usually happening. Right now it does happen, but what my experience is it happens after a bad incident or something that's happened. That's when everybody gets together, and I think trying to really have a designated place where we really address these issues locally is going to be really important. So I think that's why I feel like this is a step in the right direction.
Let me just emphasize that step in terms of primary prevention for both depression and anxiety as well as substance use in the schools. You're doing primary prevention, which could bend the cost curve, but it also changes the population we're talking about. This is not lives covered in the CCO or PEB, or this is a population. And I think as a health policy board, we have really important decisions to make as to whether we're encouraging population health, and especially in terms of primary prevention. These are two low-hanging fruits. We saw in your honeycomb, second highest rate of suicide amongst young adults. And for us to move that outcome, it makes sense to do early primary prevention outside membership in a CCO or a PEB.
Yes, exactly. And I think that is what worries people is when it gets to funding, the organizations are worried about their funding and who they cover. And that's going to be a challenge because, like you said, in order for you to do prevention, you can't just do prevention in a certain group. It's got to be.
If you wait till people have the disease, it's no longer prevention.
Yes, exactly.
Yeah, I really would like to reiterate a little bit about that conversation and what you were just saying about your ideals of what would really move the needles on some of those honeycomb statistics. I'm hoping that those standards of care that are developed and that work their way into those contract changes are not just a bunch of box checking, like how many days did it take you to get in? Did you get your assessment within 24 hours? When was your follow-up appointment? Those are important measures around operational care, but that doesn't get to population-directed changes or eliminating adverse childhood experiences before they occur, which is when you get into the why of those honeycomb elements, those are the whys. It's not that it took me 8 days to get in and it should have just been 7.
Yeah, just a quick question. I think voluntary stuff is fantastic. I think all of us have done it. It's great. It works. It's wonderful. But almost always there's someone who eventually says, the answer is not no, it's hell no. What are you going to do when the answer is hell no?
Maybe rhetorical.
Yeah.
It's a good question.
Just be a
Felicia.
No, it's what creates heartburn for me,
Yes.
to be honest with you. And I think, so you have the stick and the carrots, and so we're trying to come up with a better list of carrots, and that's been a challenge, but maybe the administrative burden is a carrot. If you get involved in this and you still, and you submit a plan, then you don't have to do X, Y, and Z. Maybe that's a carrot. I'm going to really, in addition to those carrots, rely heavily on us going out and engaging in a way that this is a really great thing. These are concerns that your community already has, you've been working towards, but you've been working towards it in these different areas. And so wouldn't it be great if you could pool that and that energy and those resources, and OHA is not telling you what you need to come up with except for maybe some priority areas, and figure out what you want to do, because there's lots of community-based reports, anecdotal information, state data, those kinds of things. And so it really is not us telling you how you should do it or what you should do. It's more of how can we support you in this really great initiative and endeavor, and we are going to hold you accountable when, if you're not meeting your marks or your targets, or if a region or locality isn't getting set up. But I don't think coming in with a hammer is the first way to do it. I think it's, what's going on? I mean, what are your challenges? And so this has been a lot of conversation in the governance and finance work group, because they don't want us to do what they've seen done by OHA in the past. And that's where they have really encouraged us to work with them to figure out what that communication strategy is, come with us as a CCO CMHP, and really partner with us around selling this and really convincing people.
So Felisa, I'm going to give you the last word, so don't ask a question that requires lots and lots of response.
On the transformation, I was just thinking about the work that you talked about on the ideal and the work that we've been doing up to this point on the Transformation Center has been very focused on a set of providers, medical directors, CCOs, and it seems like if we're going to really move the ship and these other upstream interventions, as well as this behavioral health collaborative work, there has to be some core changes to what the Transformation Center is working on and who they're engaging. And I don't know if they've thought about that, or if we flagged that for them, or if we've thought about that, but I feel like that if we're really going to shift that work, it's probably going to have to happen pretty soon to get some of these outcomes. So that's a long-winded.
So the Transformation Center
question.
is very involved in this process, and actually one of their staff who has experience in value-based payments and has done some work with the CCO is leading the governance and finance work group. So we are working to engage and align with them, but I'm also hearing you, maybe I'm hearing you say this, that you know, the group that we're talking about now is not the entire group that we need to focus on and engage.
Yeah, I just feel like I think the Transformation Center, when I think about the CCO, they did a lot of really great best practices. They do a lot of really great work with providers. I think they've helped with the peer support wellness folks, as well as the traditional healthcare worker group. And then I feel like I heard from David and you all okay, if we want to do early interventions in schools, what is the work they're doing with DHS to identify the sort of at-risk kids, at-risk families? What is the best practices around that? And what's the Transformation Center equivalent in DHS? Corrections, right, has its own sort of best practices for dealing with. So how do we infuse those best practices through Transformation Center? Teachers. So I guess if we're going to shift, the Transformation Center has to shift with us.
Yeah, that's a good point.
It could just be helpful as I don't know where in our calendar, but I mean, in effect, this is asking for changing scope, if not a changing approach in terms of the Transformation Center's work. And as you all are working to figure out how this all fits together, that could be a really meaningful conversation to get a sense of what that looks like and how to support that transfer of their work. So I'm going to cut it short to some degree. Appreciate you all coming and sharing with us.
Thank you.
Mark, thanks for coming up. Appreciate that as well, and for your work on the collaborative. So we have slightly less time than we were initially scheduled to talk about CCOs 2.0. The good news is I think we're going to spend a lot of time talking about this in our coming conversations. But Pat and Jeremy, you guys are going to give us both an update on your approach currently, what you're thinking about, how that impacts the system, and then Jeremy, if you wanted to just kind of do a little bit of information about the letter that we received from the governor. We've all had a chance to, I think, review that, but how these pieces fit together. And then for the board, I think, as we're in this kind of dynamic changing environment around both the CCO contracts, but then also thinking about our recommendations and then the charge from the governor, I think we want to be intentional about how we want to engage in the next 6 months in particular, but also moving forward around kind of policy level framing and recommendations for the system change. So just to say out loud, I think ideally, and this will be a conversation today, only 20 minutes, but in over the next couple of months, it'll be a dynamic conversation back and forth. So just Pat, Jeremy?
All right, so in your package, you've got the letter from the governor that Zeke mentioned, and then there's a two-pager that's a Gantt chart on one side and a set of bullets on the other side. This is a continuation of the discussion we started last meeting about proceeding with CCO contracts, the new 5-year block of contract period now versus deferring that for a year. And the fear that I articulated last time was, are we ready to proceed now with the next iteration of CCO 2.0 reflective contracts, and the fear being that if we aren't, then what we really do is dial in something that looks an awful lot like the status quo for the next long period of time versus taking more time, deferring that body of work and waiting. And this is sort of the last base for us to touch, but I think we've, not terribly surprisingly, if you've listened to my rhetoric over the last couple of weeks, decided that what we want to do is we want to defer the new contract process by a year to allow us to do a better job of teeing up truly CCO 2.0 contracts. I think you've heard a lot of good content today of the kinds of things that we think with more time we can better reflect in those contracts. In conversations with stakeholders about whether or not to delay, I would make two observations. There's a related question of, do we do a competitive RFP process versus a non-competitive request for applications process? And while no one has really hardcore advocated that a competitive RFP process is necessary because there's something inherent in a competition and a winner and loser kind of a dynamic, what has been articulated is a lot of feedback that really came back to whatever process is used to enter into these contracts. The contracts themselves need to do a better job of articulating what kinds of performance is required and making sure that that we're able to hold CCOs accountable for delivering that performance. And that's really a function of the contract itself, not a function of the procurement process. And to me, reinforces the notion of being thoughtful and taking more time to do that body of work. The other consistent feedback was not so much a strong argument to say, oh gosh, no, you've really got to proceed to contracts right now because of some articulated list of things. That has been much more, well, don't delay just to delay, and then a year from now we're in the same place and we haven't really done anything to deliver the next round of evolution in the process. It's use that time meaningfully and get something for it. Otherwise, you may as well just go ahead and move forward for contracts now. So with that as the backdrop, I'll turn it to Jeremy to walk through what's here, and as well as the governor's letter, and talk about how that time period lays out and what we are going to do with that time.
Yep. So, as Pat was saying, I mean, it felt like as we've dug deeper into this that there's a lot to sort of a lot of this to move forward and a lot to be gained by really being thoughtful over the next year. There's a ton of work that's already underway. Like Pat said, some of you heard here. There's work groups looking at value-based payments. There's groups looking at social determinants. A lot of that work's going to come together over the next 6 months, and so don't want to miss an opportunity to be able to fold that in. So really, the goals would be, ability to do a deeper, better engagement with stakeholders, with the public, get clearer on our targets. You all have done a great job, I think, of laying the high-level vision through the action plan refresh, and we've captured a lot of that on the back of kind of the key goals that we would want to incorporate, but in some ways need to kind of go a little higher and bring that together and really be clear about where we're trying to get to, and in some ways need to go a little bit deeper in the specifics of how exactly we're gonna get there. The way we're thinking about approaching this would be first actually needing to kind of go back and apply sort of the data and evaluations information that we have to the action plan refresh that you all have done, to get a little clear about how far we actually come on our 1.0 goals. We think we have a lot of that information. There's some gaps that this process will probably identify, but give us sort of a baseline of how far have we actually come since 2012 to be able to better understand where we want to go. So we would envision the next couple of months starting that. We've been calling it sort of a maturity assessment, for lack of a better term, of going back and kind of applying some of the data and evaluation that we have within the organization, but just need to kind of compile and bring that back to you all. We would also go back and start a sort of an administrative review of the current contract, see if there's some streamlining, some things that don't need to be in there, should be in there, data we're collecting that we're not using, for example. So those would be, and then mapping out really the sort of public engagement process. And so I would envision that would be an iterative process with you all over the next couple of months, where we get really clear on, well, as we're sort of setting the baseline of where have we come, working with you all on what are the key questions that we want to answer, and where are the best places to sort of land those conversations to get meaningful input from stakeholders that will eventually turn into recommendations to the agency. There's sort of two tracks of work. So one is really laying out that kind of where we headed in 2.0. There's also some work that needs to go into what are the actual extension of the contracts look like, and so we would need to map out what that 1-year extension would look like, and if we'd expect there's some new things we would need to fold in there. For instance, there's a couple things in the waiver, there's a couple things in the US DOJ agreement, so we need to do a little bit more work to figure out what specifically those are, but would need to pull those out and create a work plan for getting the details worked out with CCOs on that. The governor's letter, so on the back of the 2-pager really is the frame of your guys' action plan for health. The governor also submitted a letter to you all asking to really lean in a couple of key areas and really building off of, again, the action plan for health and the CCO listening tour that you did. So really focusing in more on social determinants of health and equity, on continuing to raise the bar on outcomes and value-based payment, and maintaining behavioral health improvements, and then maintaining a sustainable rate of growth and making sure that we're doing what we can to control costs, including things like high-cost drugs. So I think our overall proposal to you today is really that we will work on some of the details in the coming months as we're doing this sort of maturity assessment and work out with you all this fall really how this work all comes together over the next year.
So really, the input we'd love from you is anybody of a mind to throw themselves across the tracks and say, oh my God, no, this is totally the wrong approach and you should really move to contracts quickly?
I think the conversation today has been very informative. The great work on the metrics committee has got us very close to this, but there's obviously they're going to do very important work in the very near future to sort of, I think, come to a point of conclusion. The behavioral health group, has made progress, but also could, I think, very much inform contract negotiation by working with the metrics committee. We will have better outcomes and better levers for contract negotiation. I think there's, as I mentioned, I think there's really important discussions as to how we unpack social determinants, how far upstream do we move, what populations are our denominator? Is it just lives covered, or are we talking about populations at large or criminal justice system, and what are those connections? So I think those are really important discussions to have during this delay. One question I would ask is there a mechanism, if we're going to extend these contracts for a year, is there a mechanism to tell the CCOs what we're thinking about today, what the priorities are, to give opportunity to innovate over the next year, to come back with ideas that are moving in these same directions?
Yeah, I think that's a good question, and I'd say the answer is yes, that we're able to communicate this letter, communicate this draft document as a final document, and begin to articulate that work while we're beginning to talk about how to firm up our understanding of how it translates into contract language.
Because I'd hate to see all innovation stall.
Correct.
Over the next year,
Right.
just to do more of the same. If we're going to extend, say these are the directions we're looking for innovation.
Yep.
Question. So this piece at the bottom of this front page on the draft discussion, it says it's expected that some new contract provisions will be included in this phase 1 extended contract. So are those 3 bullet points going to be incorporated into the extensions? Am I reading that correctly?
Yes.
Yeah, it's the things that really can't wait that we need to begin to include into the next round of contracts.
So everything else in the contract would remain as is, unchanged, but there's going to be some elements added around these new requirements?
Yeah, for the most part.
Yeah, I mean, this isn't an exhaustive list, but it's the kinds of things that would be in that, and it would not be a large list.
Okay, will we be privy to any of these items? What would these be? What's an example of a new managed care regulation?
Yeah, so there are, so we have, frankly, we have more work to do to be able to pull out exactly what these are, but these are the sort of the buckets that we've been hearing from staff of, well, if you do a delay, don't forget there's some things that we really got to get folded in into the next round of contracts. There's some pieces, for instance, around the waiver that we got approved last year included moving dual eligibles into CCOs. That really can't wait. That's something that we are ready to go on and need to be able to go on to meet the waiver requirements. So there's a few more things like that we need to go back. The sort of buckets that we've identified are the USDOJ agreement and what pieces of that really need to be started to be folded in now. There's a whole set of new managed care regulations that came out from the federal government, and might be some pieces in there that have not yet gotten folded in. We need to do a review of that, and then the pieces in the waiver that can't wait as well.
Well, I hope that they're not too large of change. I mean, you could end up into this contract negotiation period that's just as substantial and complicated as 2.0.
Yeah, our
For
goal.
those three bullet points could be pretty substantial.
They are, and our goal would be to hit the things that we really have to get in, the things that are more substantial and need to really have a more thoughtful conversation about where we headed would be more the 2.0 phrase.
And, I mean, it seems that it would be good to signal there will be payment issues for equity and social determinants. There will be. It's going to be in there, so let's engage now. Even though this is a temporary one-year thing, let's start that dialogue and figure out how to do that.
Yeah, and these are conversations that we need to start immediately. It's, we can't wait 6 months and then go out and start talking about what it is that we want to try to build toward.
So can you say a little bit more detail about the process for the inclusion or the collaboration across the stakeholders in that planning period?
Well, I mean, it's something we really want to work out with you all over the next couple of months. I mean, I think that I see the next 2 months probably roughly being doing this sort of maturity assessment. Where are we? Figuring out what really has to be in a contract and getting that an extension and getting that work going, and then working out with you all. What are the key questions that we need to put out there publicly and start to engage stakeholders in the public and over the next, and what's that process look like? So that's something we would want to work out with you, and I think that will help tee up, expectations with CCOs and stakeholders and others around the direction that we're headed.
So is that, I guess to be more concrete, over the next couple of months, what's the role of the policy board in response to the governor's letter? Is so that we can give, you all enough sort of advance notice to know how to do the community collaboration conversation?
Yeah, I mean, I think we would be, bringing back some proposed work plans for you all to look at and give us feedback on and approve.
Just to modify that a little bit, I think it's somewhat our responsibility to figure out what our role is.
Yeah.
And so I think we can do that jointly with the staff. I'm jumping a little ahead because I wanted to give people an opportunity to weigh in, but I would like to see if we can't get a couple of us, I know I want to be involved, but maybe one or two other members to work with Jeremy and Pat and the staff to be able to come back to that in our next meeting and share some plans that are kind of jointly agreed to in terms of thinking about both what's the capacity, but also what's the interest from the policy board and the expectation in terms of the role we'll play around that process. Felicia, you wanted to jump in.
I thought that there was also a dental requirement somewhere either in the legislature or around to have to incorporate something around dental in our new contracts.
Could be, I have to go back and look.
And so I just don't want us to lose that if we have to do that now, and I feel like that's been a...
Oh, you mean the representation on the governance structure?
I think it was something else, but maybe it was the representation on the governance structure,
So I appreciate the way you all have laid this out. We've had some conversation, but from the framing, it's clear. I mean, one of the questions I think that people had is, does the health authority have the ability to just do an extension, and/or is there any sort of legislative action required? Looks like from the approach, the sense is that you have the capacity to do this. That's great. If there is any specific legislative action required in the short session that relates to this process, I imagine we'll want to surface that quickly, and then I think that's a place where the policy board might play a role as well in supporting that. particularly given that we've had an ongoing dialogue with the legislature around the recommendations process. So I wanted to flag that out loud. I appreciate the structure of the phasing here, and as I read it, in effect, in phase one, that's really the work of the health authority, but it feels like to some of these questions, that's a place where having an ability to inform the policy board of some of those changes and what that looks like will be important. Phase two feels like that's a space where we've got a lot of work to do together. And as we look at that public input process box in particular, I'm really interested in making sure that we're paying attention to some specific stakeholder groups, and that I think the policy board has opportunity to do some engagement there. The CCOs themselves and their leadership clearly. I think also thinking about the right role for client and consumer perspective and voice in that process. And I get that this timeline is gonna feel really short really quickly as well. But just want to do that. I appreciated your framing, Jeremy, of there are some places where we need to go a little bit higher, and there's some places where we need to go a little bit deeper. And I think as we work together to get clear about what we think those areas are, where the policy board has a role in going higher and where the policy board has a role in going deeper. And then the last piece I was going to say is I really like this framing of the maturity assessment. I think there's a good opportunity there to learn a lot from a data perspective in terms of what's working and where are we in relation to where we thought we would be. There may be some questions and some analysis that doesn't get resolved in that kind of a process that we as a board may want to think about. So as I think back on some of our conversations, one of the reasons why we didn't take action as a board or make a recommendation around the formal structure of CCOs, not-profit, for-profit, was the fact that we don't really have good analysis of is there a distinction between those things. I'm not sure that that's a maturity question, but it feels like it's the kind of question that we may want to look into. I think there's a question of what the pros and cons are of having multiple CCOs representing a singular geography, and I know that's only a couple of places in the state where that happens, but it's one of the things that we've heard come up as either an issue or as an opportunity. So I just think as a board, we may think about where there are some specific questions that don't come out of a direct kind of scrub of existing data that the health authority has in its relationship with CCOs, but is more specifically about kind of these larger questions, which may not be about maturity, but may actually be about choices or decision points that were made on the front end that we either need to affirm and or say we need to think about moving in a different direction. And not all of that has to be completed in this frame, but we've got this new window that I think gives us some space. So I would just say to you all as board members, please let me know, let staff know where you think there might be some of those critical questions that we want to consider.
I would just encourage us also that we should have a process done for this, not the process completed, but a process outlined by January. Because I think if we're not ahead of the game on this, then during February, the legislatures will want to develop a process for us.
Yes.
I would also, I double down on that and suggest that we actually task ourselves as a board to some additional work sessions in order to be sensitive to the timeline, to give the right level of guidance and consideration. You're bringing up some very big, heavy lifting questions that we've talked about, but surface level conversations perhaps, and so to do deeper dives in some of that content could be really important.
Yeah, especially I think being able to identify it quickly to the extent that it will require some outside work or research or those kinds of things so that we can have that work timely.
Yeah, and for you all to identify the resources to be able to do it.
Yeah, I mean, just to be really explicit, I mean, what we're proposing here is that this sort of results in a set of recommendations from you all to OHA by the end of next year around some of these key questions. And then I think, Zeke, to your point about kind of what we'll learn from this maturity assessment, I think we'll have some areas where we have data. For instance, I think we can measure fairly easily how far we've moved from fee-for-service to alternative types of payment methodologies. I think we can measure that. I think it's also going to identify some areas where we weren't really very specific in 2012, like what does integration actually mean, and those might be some areas where it's not as much as setting a changing goal, but being more specific about where do we want the system to go.
So in the month-by-month schedule, I'm imagining, right, a workflow, that we would lay out the plan to say during the course of the year, this is sort of the big hurdles and rocks we want to accomplish. So my next question is connected to what is the amount of CCO involvement and inclusion in those conversations, and how do we set that table so we receive, not all of the feedback all at once, but in a kind of organized manner so we can digest what we're hearing?
So I think that's exactly what we want to work out with you in a plan. There's a number of committees, as you know, that you already have established where some of these conversations are already happening.
Right,
So I
sure.
think it's a matter of tapping into some of those and maybe sending them some specific questions that you want answered and be able to outline publicly what the calendar process is so
Yeah.
folks know when and how to engage.
So if there are any volunteers, other board members who are at least in the next 30 days willing to work with me and Jeremy and Pat and the team around fleshing out what we do know in terms of a recommendation for that process, as well as what other questions are needed there. I think that will require some additional work sessions for that smaller group in that 30-day period. Anybody ready to jump on board?
I am. I think, having participated in the listening sessions
Yep.
themselves, I'm deeply invested in, trying to figure out how to translate the voice that we heard in the communities into this next process. So sign me
Great.
up, yeah.
Great. If anybody,
Zeke, how long ago was it when we had was it our January meeting in Eugene where we did our strategic planning kind of
Yeah.
session?
yeah,
2 years ago?
it was last January. We did. So we've typically done a retreat. I'm not sure if we've typically done a retreat in January, February. We
Okay.
have slated, I think it's February as a time for a retreat again. That may or may not be the right time for the retreat, but
I'd be up moving that. I like the point of getting this discussion done before legislature
Me too.
starts. I think so. I would support moving that retreat up.
okay, so we
Likewise.
can look at A, moving the retreat, we can look at B, whether or not and how we want to maybe extend some time periods for our ability to meet in that space. And I'll just say out loud that in my conversation with some specific legislative leaders, they reinforce that idea that they're looking to the Health Policy Board to have some clarity about that direction. And the more clarity we have, the more likely it is that they'll be in a position to work on other things.
So they're asking for more of a proactive rather than reactive.
Correct. Great. So at this point, Brenda and I will work with the team. And if anybody else wants to participate, you'll let me know. And I'm sure you will give us all kinds of input and feedback about things you want to see there too. But please take that seriously in terms of what you want to make sure we cover and what'll still be a pretty tight timeline. And thank you, Pat and Jeremy, for putting this together, and just appreciate the transparency in terms of the issues you're working through on the
That's
process.
very helpful.
Thanks. This meeting is adjourned. Our next meeting is November, moving quickly, 7th. Again, it'll be at the Astoria City Hall. It's scheduled to go from 8:30 to 2, and we'll see you all there.